with a special person. In academia, we have people who are experts, people who are greats, but then there are certain people who are the greatest of perhaps all times. And it's a privilege for the City of Joy to hold and host perhaps the doyen of hepatology for generations to come and our generation, Professor Patrick Kamath, who is an inspiration for anybody who is even remotely attached to hepatology. It would be a day which will be filled with real-life examples, common scenarios, tidbits of hepatology, and things which we tend to forget in real life, but again have to come back to it. I can guarantee you on that aspect that those questions and those cases would be something which would stick to your mind forever. Without any further ado, we would start to kick off the program, and to initiate the program and its outset, I would like to call upon the stage President INASL, Professor S.P. Singh sir, to come on stage, please.
Good evening. As the President of INASL, it's a proud privilege to start the proceedings today. As you know, INASL is the most important society of hepatologists of this country. It's one of the biggest societies in Asia. And if you look at the world also, world over, it's one of the biggest national societies. At INASL, it's always our endeavor to promote research and education, conduct CMEs, and this year we have started a program with this program from the City of Joy. And it's a great moment that we have none other than Akash was looking for words, how to describe Patrick. We have none other than a legend. Or for people, ask street smart people, he is the Amitabh Bachchan of hepatology. This is what I would say. So I will not come in between you and a legend. I am too small a man. And straight away, we'll start off with the lighting lamp ceremony. As is usual, we'll be having the inaugural ceremony by lighting the lamp, and then we'll start with the rest of the program. And for this, may I invite Professor Patrick Kamath onto the dais. Professor S.P. Mishra, Dr. Konar, please. May I now request Akash to conduct the rest of the ceremony. Akash, please.
So what's the first step that you take towards liking hepatology is when you're faced with abnormal LFTs. And that's where we start with the first session on approach to abnormal LFTs. Can we have the chairpersons for the session on stage, please? Professor Ashokananda Konar, sir, who is the Senior Consultant at Department of Gastroenterology at PLS Hospitals, Kolkata, and Dr. Kingshuk Das, sir, who is Senior Consultant and Adjunct Associate Professor, Department of Gastroenterology at Apollo Multispeciality Hospitals, Calcutta. I would request the chairpersons to please invite the panelists on stage, please.
Good evening. May I call upon Dr. Anirban Chatterjee, Senior Consultant, Department of Gastroenterology at CMRI Hospital, Kolkata. Dr. Bhaskar Bikash Pal, Consultant, Department of Gastroenterology, PLS Hospital. Dr. Somnath Mukherjee, Senior Consultant, Gastroenterologist at CMRI, and Dr. Shayambhu Banerjee, Consultant at Bankura Shevaniketan Hospital. May I have all the panelists here? Shall we start then,
Yeah.
Dr. Kamath?
Yeah. Thank you so much, Ashok Kumar. SP, thank you so much for the shirt, and to INASL for welcoming me here and for inviting me to Kolkata. And Mahesh Goenka is not here, but he gave me the privilege.
We can't hear from here also.
Console, we can't hear him from here also.
Can you hear me now? At the back? Oh, good. Yeah. And I think the last time I came to Kolkata, Dr. Mahesh Goenka gave me the privilege of meeting one of my heroes, the pioneer in oral rehydration solutions. So I was very privileged to meet him. So for those who have not been to one of my previous sessions, this is how we'll go about it. I'll present a case, and then I'll give you different responses. I want you to put up your hand to tell me what you would do. Then I will ask comments from the panel. I'll give some teaching points, and then we'll have time towards the end for brief discussions. So this is just practice, okay, before we actually start the case. Okay, so here is who had the second highest strike rate in the most recent World Cup. Let's see, show of hands. Glenn Maxwell, Klaassen, 1 for Klaassen, Rohit Sharma, 3 for Rohit Sharma, Markram, 1, 2, Mendes. Panel, what do you think? Second highest. So that's the question. Maxwell. Okay. So panel, and this is the strike rate. So Maxwell is certainly number 1, and Klaassen. So this is how we'll go about it. Now let's start with the case, okay? 61-year-old, whatever's in blue is highlighted. 1 week history of jaundice, light-colored stool, dark urine, pruritus, fatigue, fever, no chills. Dull, continuous right upper quadrant pain. Nausea, no vomiting. So when you get this picture of jaundice, so this is how I want you to approach it. So when you see this picture, who's thinking this is extrahepatic cholestasis? One, intrahepatic cholestasis. Your differential diagnosis is extremely small. One is gallstones, perforation, embolic, and hemorrhage into a tumor. Only 4 conditions will give you pain rising very rapidly to the peak. So this is not like biliary colic. Okay. So this is the additional history. Hypertension, hyperlipidemia, no alcohol, amlodipine and carvedilol for hypertension, esomeprazole for reflux. 6 weeks prior, had jaundice. Before he had the jaundice, had COVID, glucocorticoids, meropenem, ceftriaxone, and doxycycline. And that was a time where half the people had COVID. Antibiotics were discontinued, and when the patient left the hospital, the patient felt perfectly all right. No problem at all. So it's not been on any medicines now for about a month, and we've got these tests. So based on this, what do you think now? Do you think this is viral hepatitis? Could this be viral hepatitis? Yes, could be, okay. What about drug-induced liver injury?
Yeah, I think I would go with drug-induced liver disease.
So he has not been on a drug for 4 weeks, and then gets the jaundice.
But if we have a idiosyncratic reaction, so it can be between anywhere between 5 to 90 days after the exposure of the drug.
So typically, what are the rules? If you stop a drug,
it should go away.
And the liver tests have not decreased in 4 weeks, it is unlikely related to the drug. So makes it unlikely related to the drug here. Stones we already ruled out. Pancreatic cancer?
No, sir. The clinical presentation doesn't fit.
Possible. Okay. Lymphoma?
Again, unlikely, very short history, so.
Okay, so we've narrowed it down to virus, pancreatic cancer, lymphoma, okay? So initial examination, this is initially, patient was jaundiced, bilirubin 3.5, direct 2.9, so about 80% direct, ALT 495, AST 127, alkaline phosphatase 251, ABC serology, HIV, immune panel, all negative. So, this is basic, I only go over basics. Normally, in a person, the bilirubin, is it 95% conjugated? Let's see, show of hands. Normally, 80% conjugated? Conjugated 80%, okay. 95% unconjugated. 80% unconjugated. Okay, so about equal, everyone. So when you say conjugated hyperbilirubinemia, what do you mean? Is the bilirubin 90% conjugated, 70, 50, 20, 1 for 2, 3, 4, 5 for 20? Okay, what do you think? Is the bilirubin predominantly conjugated or unconjugated? Question one. What percentage?
It should be, normally, I think it's more than 80% conjugated.
Normally?
In the normal.
Unconjugated, how much?
80%.
80? 80% unconjugated. Okay. So, and when do you say this is conjugated?
So, sir, the previous teaching was 50%, but now it's more than 20% conjugated is called
So things
direct
have
hyperbilirubinemia.
changed based on how we do the testing. Okay. So the old way of doing testing was the Vandenberg reaction was very complicated. The new diazo methods, bilirubin is almost exclusively unconjugated. So there's very little conjugated bilirubin. And if it is greater than 20% conjugated, this is conjugated hyperbilirubinemia, okay? So, this person has conjugated hyperbilirubinemia with this picture. So how are you going to interpret this now? So you had your initial jaundice, so is this now mixed hepatocellular? Is it cholestatic or is it a combination? Which one is it?
It's a mixed type of...
Good. So this is mixed. So here's how we're going about it. So for the audience, we look at an R value. R value is how many times is the ALT elevated as compared to the alkaline phosphatase. So this is the R value. So this is the interpretation of the R value. More than 5 is hepatocellular injury. Later I'll tell you what causes you think of. 2 to 5 is mixed, as the panel clearly pointed out. And less than 2 is cholestatic injury. So this patient has a mixed pattern, okay? So again, for the audience, you're physicians in practice and you see the patient. This is how you should evaluate alkaline phosphatase. Check the alkaline phosphatase, and if it's elevated, make sure that they did it fasting. And why fasting? Do you know any groups where it goes up?
Yeah, because in the after the postprandial period, the intestinal alkaline phosphatase, they can go up, especially in people who are O and B
Very
blood
good.
group.
So remember this, O and B, intestinal alkaline phosphatase can go up after a meal, A stays about the same. So if the alkaline phosphatase is elevated, before you get too excited, make sure it was done fasting, okay? If it is elevated, you don't know whether it is bone or whether it is liver, so do the GGT. If that is normal, it's of bone origin. Then you look for other causes, osteomalacia, Paget's disease, metastatic disease. If GGT is increased, that is hepatobiliary origin. So is everyone clear? Alkaline phosphatase, hepatobiliary origin. Okay, now we have to go a little further. So in this case, if it's of hepatobiliary origin, get a right upper quadrant ultrasound. If the ducts are dilated, what will you do?
Get an MRCP done.
Or ERCP, depending on that. Good. If it's not dilated, depends on where you are. You can check the AMA. If the AMA is positive, ultrasound normal, or if the AMA is negative, liver doesn't look quite right, you will do a liver biopsy. If the AMA is negative and ultrasound normal, what will you do?
Sir, I'll just follow up this patient's problem. Depending on the degree of elevation of alkaline phosphatase.
Very good. So it depends on symptoms and the degree of elevation on that. So assess the degree of elevation. More than 50% elevated, sorry, this should be symptomatic. You will do usually a liver biopsy, but you have to think of something else. If it's less than 50% elevated and asymptomatic, you can watch them and follow up the alkaline phosphatase again. Clear how to evaluate alkaline phosphatase? Okay. Next is your approach to jaundice. We'll come back to this patient. The patient has jaundice. See if you have indirect hyperbilirubinemia. What are your possibilities? Indirect hyperbilirubinemia, only two possibilities. Very good. So, if there is anemia or no anemia, Gilbert syndrome. If there is anemia, this is a hemolytic anemia. If it's a hemolytic anemia, what are your possibilities? Red cell has no nucleus. It has membrane. So you have membrane disorders, which is like sickle cell. It has a hemoglobin, so hemoglobinopathies. Or it has enzymes, so it's enzymes. So only three causes of hemolytic anemia. So very easy to work up hemolytic anemia. Now let's go to direct hyperbilirubinemia. Is everyone following? Calculate the R value. Greater than 5, hepatocellular. Think of viral, drug, autoimmune hepatitis. 2 to 5 is a mixed pattern. You can get that with alcohol. You can get late stages of viral hepatitis, drug, autoimmune. So later stage, you can get the mixed pattern. But if it's a cholestatic picture, we think either of obstruction or granulomatous or infiltrative diseases of the liver. Okay, so this is our work up here. So this is how we approach elevated alkaline phosphatase, elevated jaundice. Now back to our patient here. R value 4, all serology is negative. What do you want to do next? Remember we said, what do you want to do next?
An ultrasound.
Very good. So it's simple. The workup is very simple. So I'll show you a complicated case, but how a simple approach we can get a diagnosis. So yes, we want an ultrasound. So ultrasound shows you thickening of the gallbladder, seen. You can see that normally the gallbladder wall is 3 millimeters. You can see it's 14 millimeters, and you can see it's elevated here. No lymph nodes, no hepatosplenomegaly, no other masses. So does this patient have acalculous cholecystitis? 3 features of acalculous cholecystitis. One is thickened gallbladder wall. So fits in with that. What are the other 2? On ultrasound we're talking about. Fluid, pericholecystic fluid, and ultrasound Murphy sign. They're very tender over that, okay? So that will tell you acalculous cholecystitis. So this doesn't look like acalculous cholecystitis. The features, you must think of this, especially those of you physicians, when you're looking after a patient who did not come in with liver disease, is in the hospital, especially intensive care, not eating for many days. They're critically ill, and then you see they've come in for some other reason, then they get jaundice, they have fever, they have pain. You'll see the liver tests are going up, no particular pattern, typically mixed with a white cell increase. This is acalculous cholecystitis. You need to drain the gallbladder very quickly. So remember that. So this is not acalculous cholecystitis. And I told you the typical ultrasound findings. Okay. Now what's your diagnosis? Ultrasound CT scan doesn't show you anything in the pancreas, so this is not pancreatic cancer. No stones, no drugs, virus is ruled out. Is this lymphoma? Yes? Or no?
The duration of the history is 1 week in the case?
The history is 1 week.
1 week. So that slightly goes in not in favor of lymphoma?
Anything else against that? No lymph nodes, no hepatomegaly, no splenomegaly. Yes, this could be primary hepatic lymphoma, but that's not common, okay? So now you have to start thinking something else. It's not quite this. So what do you want to do now?
Sir, do we check for the atypical viruses?
Good. So we look for other viruses. Good, I agree. Anything else? You'll check for COVID. Good. So, cultures, CMV, EBV, all negative. So then the patient was referred to us. Now the jaundice is even worse. Patient has got fatigue, high-grade fever, swelling of the lips and face. On exam, liver's tender now, little bigger, face, eyelids all swollen, no skin rash, no spider nevi, nothing for chronic liver disease here. Hemoglobin 12.9, neutrophil counts have dropped, bilirubin has gone up, alkaline phosphatase is up, SARS testing is negative. Ultrasound, again, this is a repeat ultrasound, doesn't show much change. So what do you want to do now and why? Now what are you thinking of and why? So whatever you do, you have to have a reason for doing it, okay? You're thinking of some diagnosis, so what do you want to do now?
Ferritin and triglyceride to rule out.
I'm getting an echo.
Oh, sorry. Serum ferritin?
Very good. Ferritin. So this is one of your take-home messages. Undiagnosed jaundice, check ferritin, okay? Why do you want to check ferritin?
So to rule out HLH.
Very good. So remember this. So that's your teaching point here. Approach to jaundice, viruses, all the common. Once you've ruled that out, start thinking of other things. Okay. Ferritin 2 to 9.2, CRP elevated, D-dimers elevated. So anytime you get a ferritin greater than 1,000, okay? Remember this, greater than 1,000, especially physicians. What are you thinking of? What are your possibilities? HLH is one, I agree.
Adult onset Still's disease can
Very
cause.
good. So those who look after rheumatology patients know that adult onset Still's disease, it's a good marker for how active the disease is. Very good. What else? Iron overload?
Yeah.
Hemochromatosis? Anything else? Remember, in viral hepatitis, if you check the ferritin, it goes up. But it typically parallels the AST, ALT elevation. As the AST and ALT go up, because it's inflammation, you'll get ferritin going up. When the AST and ALT have come down, you won't see the ferritin going up. Okay, so this is, you'll see it in viral hepatitis. hematological malignancies, adult onset Still's disease, and HLH. Okay. So what do you want to do now? Are you sure this is the diagnosis? Is this enough for you for a diagnosis?
We need to work up further for HLH, so I'll test for triglyceride, serum triglyceride.
Good, very good. So, liver biopsy is where we want now. We are running out of things to do. So, liver biopsy shows hemophagocytosis. There are other markers for HLH. So, hemophagocytosis you can get with viral hepatitis 2. So, that's not enough for you to say this is HLH. You need other criteria I'm going to show you. So, TNF elevated, triglycerides typically tend to be elevated here, fibrinogen, and then based on this, you have a score. You don't need to remember the score. I'll show that to you in a bit. So this is what the liver biopsy showed. So you can see that's a macrophage with red cells. So this is hemophagocytosis. Those are macrophages. That is apoptotic bodies in here, and a macrophage consuming a red cell on bone marrow. So typical findings of hemophagocytosis. So you have to have 5 out of 8 criteria. No need to remember this. Fever, splenomegaly, cytopenias. Our patient had neutrophil less than 1,000, but platelets were initially okay. Ferritin over 500, hypertriglyceridemia, hemophagocytosis, and low NK activity. So you put everything together and you come up with a score. So here is what we think happened to the patient. So patient had SARS-CoV. Any viral infection activates the immune system, you get a cytokine storm, which in post-SARS, you get 2 hyperinflammatory syndromes. Soon after, so this is a bit unusual in our patient, soon after, so in about 2 weeks, you start getting features of HLH, and by about 12 weeks, it decreases. Our patient started getting it about 6 weeks. So it's within it, but less common. Whereas what comes on later is called the multi-system inflammatory syndrome. And these are the differences. Has anyone seen HLH post-COVID? It is common. You've seen that. And the inflammatory syndrome, it's typically described in children, but you get it in adults too. And remember, COVID is coming back, so keep an eye on this. So these are the hyperinflammatory syndromes. They get fever and constitutional symptoms. So on this side, whatever I'm showing you now is part of multi-system inflammatory syndrome. They get neurological symptoms, conjunctivitis, nausea, vomiting, diarrhea, pericarditis, thrombosis, renal failure. This is part of multi-system inflammatory syndrome. Hepatosplenomegaly, cholestasis, rash, ARDS, and hemophagocytosis is part of HLH, okay? So it's important when we are thinking going forward, but in both you will start steroids. It's what you will do if steroids don't work, which is different. So follow-up patient was treated with prednisone, had steroid-related diabetes, and so we added azathioprine, and 18 months later, the patient is doing quite well, okay? So here are our take-home messages, very important. If you have undiagnosed jaundice, you've done all the tests, you still don't know. Fever, cytopenia, and splenomegaly, absolutely right, get a ferritin done in these patients. So check inflammatory markers, which is ferritin. You can get HLH as complication of viral, hematological, and autoimmune diseases. And steroids are beneficial. Anakinra is the other drug that is used if steroids don't work. So your homework, all of you, any postgraduates here? No one? Important to know management of HLH. Maybe all of you can go home and read about it. Also, liver gets involved in hematological disease, so read a little about this. And post-bone marrow transplant, you also get liver disease. Okay. So we have 5 minutes for questions now. It's right, 5 minutes, right? Yeah. Questions, anyone? Do you want to make comments? Please make comments. Is your approach the same? Do you do something any different? Please let them know.
Sir, in this suspected HLH, would you rather get a bone marrow biopsy rather than a liver biopsy in this sick patient, or would you get both?
Yeah, so that's a very good question. So the question is, why did we do a bone marrow biopsy? Because the initial reading of the liver biopsy was they were not clear that there was hemophagocytosis. It was not very prominent. So we got a bone marrow biopsy, but then on rereading the biopsy, we did find an area of that. But you're right, if the liver biopsy showed it, there's no need of bone marrow biopsy. You're correct.
What I was trying to say is, would we rather, if we did one, would we rather get a bone marrow biopsy rather than a liver biopsy?
So good question. If you have a choice between liver biopsy and bone marrow biopsy, where would you go? I go to where I think, this usual question, why do people rob banks? Because that's where the money is. So we try and see where is the money here, where will I likely get a diagnosis? The liver seems involved more prominently here. There's only neutropenia, remember? All the rest seemed okay. So there's more money in the liver biopsy.
Thank you.
Questions? SP? So the question is, if steroids don't work, what do you do? The next is for HLH, it is anakinra. Let me go back a bit. So there is malignancy related and non-malignancy related. So malignancy related, it's cyclophosphamide. Non-malignancy related, it's steroids. If steroids don't work, then it's anakinra, interleukin-1 inhibitor. If that doesn't work, then TNF blockers have been used, and tofacitinib has also been used, JAK2 blockers. But steroids, if they're not responding to high dose of steroids, you're probably not got the right diagnosis and more likely a malignancy. SP, did you hear? I could hear you, but I can...
Yeah, can you hear me now?
Yes, I can hear you.
Okay. If it's the same criteria of HLH 2004, there should be at least 2 lines of cell count to be low, 2 cytopenias at least out of 3, platelet, neutrophil or hemoglobin. Here at least only 1 cell line is low, absolute neutrophil count is less than 1000. Whether that fits into the same criteria, at least there should be 2 elements.
So the question is related to the absolute neutrophil count?
Yeah, that's only one here, but there should be, according to definition, there should be 2.
So we didn't take that as a criteria. We've got 5. I showed you 6, but that's not a criteria. The criteria is supposed to be all 3 elements are reduced. That's the criteria. So this is, and it only gives you a probability. So this was 79% probability, that is HLH. And remember, these patients will deteriorate very quickly. So the bigger thing is, what if you're not sure this is HLH, you don't have any other diagnosis? I think it's quite reasonable to use steroids. You know, it's just that your probability increases. So the ferritin is elevated, you've ruled out all other causes. Even if you don't have all criteria, I think it's reasonable to use steroids.
Sir, among steroids...
Ashok, do we have time? Do we have time?
One more question.
Okay.
Yeah, just last question.
Sir, I have a question. Actually, this year I got 2 cases post-dengue HLH. So my question is that, in this case, patient actually very toxic. So in this case, whether we should opt for pulse doses of steroid for 5 days followed by oral, or we have to stick to the oral prednisolone?
So the question, I think, is related to how you give steroids. Remember, this is a condition which has come up most recently. So this patient required a long dose of steroids. You know, HLH, there are reports even before COVID that it takes over a year for them to get better. So you have to follow them, look at the tests. So follow-up of any disease and any condition is clinical. How are they feeling? If they're feeling better, that's what I want. They want biochemical. Look at the labs and the radiological. Here we don't worry too much about that, and there's histological. So in this condition, clinical, if they're feeling better, the labs are getting down, we'll start tapering off steroids.
Thank you, sir.
I think, thank you, sir. Excellent teaching. We wanted this and we want to come over here and learn from you, sir. It's just beginning. I think everyone should clap, and really, this was the thing we are waiting for. Thank you, sir. Thank you all. Cheers. And all panelists.
Yeah.
We hand over the mic to Akash. Yes, sir.
Thank you, panel. You were very good. Thank you.
Thank you, sir, and thank you, everybody. Just a note, the felicitation for all the faculty members, chairpersons, as well as the other faculties would be at the end of the session, end of all sessions together when we wind up. So we move on to the second session, to some things which is always in the news and is recently more in the news, which is non-alcoholic fatty liver disease, or currently known as metabolic dysfunction associated or steatotic liver disease. So for this session, I would like to call upon stage the chairpersons for the session, Professor S.P. Singh, sir, President INASL, and Dr. Sujit Chaudhary, sir, Senior Consultant and Head of the Department of Gastroenterology at AMRI Hospitals, Kolkata. And to take away through this session as the clinical discussant would be Dr. Deepika Kedia.
The panelists for this case presentation is Dr. N.P. Bohidar, who is a Senior Consultant and HOD, Department of Gastroenterology, R.N. Tagore Institute of Cardiac Sciences. Dr. Somnath Mukherjee, Senior Consultant and Department of Gastroenterology, CMRI, Kolkata. Dr. Bikash Prakash, Consultant Gastroenterologist and Hepatologist at AMRI Hospital. And Dr. Manoj Agarwal, Senior Consultant, Department of Gastroenterology, Bellevue Nursing Home, Kolkata. And Dr. Akash Rai, who is a Consultant Hepatologist and Liver Transplant Physician in Institute of Gastroscience in Apollo Hospital, Kolkata. So, Dr. Deepika, please start your case.
Thank you for inviting me to this conference. Basically, Dr. Patrick is the star here, but just to give him some rest, I'm doing this case presentation on NAFLD. My slides are not in the way he was doing the presentation, but let's go through the case. So non-alcoholic fatty liver disease, we all know is fat, largely triglyceride, exceeding 5 to 10% of the liver weight, which is because of failure of normal fat, liver fat metabolism, either due to a defect of normal liver cells or excess delivery of fat, fatty acids and carbohydrates. And we have to show an evidence of hepatic steatosis either by imaging or by histology. And there should be no other causes of secondary hepatic fat accumulation like alcohol, some medicines or hereditary disorders. And now we know that NAFLD is a hepatic component of metabolic syndrome, and ASLD and a lot of other organizations all over the world have given the new name MSLD, which is metabolic dysfunction associated steatotic liver disease. But somehow we are tending to stick to NAFLD for now. So the case here is a 43-year-old patient, male, who lives in Agartala and owns a small restaurant which he runs with his wife. His first visit to me was on the 7th of August last year because he had retrosternal burning for 1 week. He had a minor road traffic accident. He was resting at home while his wife was at work. So for 7 days, he drank 180 ml of alcohol, basically whiskey per day, did not eat properly, did not drink enough fluids. His wife found this out and he got him to stop drinking. She's already my patient, so she got him to see me. And he had past history of alcohol intake once a week between 60 to 120 ml per week. He was not exercising at all of any kind. And remember, they owned a restaurant, so half the time his food intake was very oily and a lot of red meat. No history of hypertension, diabetes, dyslipidemia, or any operations, and he was absolutely on no medicines whatsoever. So when I saw him, his weight was 77 kilos. His height is 166 centimeters, which is 5 foot 3 inches tall, BMI of nearly 28, waist circumference 96 centimeters, BP was 130/83, and he had a tachycardia. Apart from a mild tremor, he had no asterixis, he was very dehydrated, and abdomen showed a liver span of 16 centimeters, but that was non-tender, no ascites. Rest of the systemic examination was normal. I mean, I thought the alcohol he drank for 1 week caused him to have some amount of hepatitis, though not the classical alcoholic hepatitis, but probably he had GERD with NAFLD. So, Dr. Bohidar, do you agree with this provisional diagnosis?
Obviously, I'm not talking about the GERD, that's fine. The alcoholic hepatitis with NAFLD, if you are considering the new nomenclature, there we have a subgroup. So, alcoholic liver disease, ALD.
Because he was drinking a lot of alcohol the week before. I mean, though he's saying 180, but I think his wife was saying he was drinking much more.
I think the history that you have written is as if for the last 7 days only he was taking alcohol.
Yeah, but before that he was drinking once a week, probably more, but...
So, well, in that case, you can just say alcohol hepatitis. But I would like to put in the new subcategory of the new nomenclature.
I mean, he's not jaundiced yet.
Yeah, not yet.
He's not jaundiced. So, I mean, or we can say alcoholic liver disease or abnormal liver function test because of excess alcohol intake.
Even then, I would like to put it there.
So, okay, what would you say, Dr. Mukherjee?
I mean, I think what you are trying to highlight is that the alcohol history is a little bit unreliable, which I agree with you. He has had a binge before, and then he probably was consuming more alcohol before rather than once a week.
So on a background of probably NAFLD.
From that premise, alcoholic hepatitis with NAFLD is a reasonable diagnosis at this stage.
So I just want to show you the blood test we got when the patient came into me. His platelet was slightly low, 147. INA was sort of 1.2, just above normal. ANA was negative. He was not diabetic. His viral markers were all negative. And his bilirubin was normal, though his AST was 92, ALT 211, and gamma GT was 308. Albumin was preserved at 4. So what do you think, Dr. Prakash, of the liver function tests and the bloods?
First, when we come to the CBC...
Can you be a bit louder? I can't hear you here.
First, we look at the CBC, ma'am, and with low platelets, that gives me two diagnoses. The patient has had an alcohol abuse. So maybe because of a long-term intake or because of the components of metabolic, he has a chronicity in it, and the patient has developed cirrhosis. All the spleen size is normal, or it can be a part of alcoholic hepatitis. INR again high, that can be a part of binge drinking which he has done for past 1 week leading to alcoholic hepatitis, although in absence of jaundice, definition wise we cannot put it alcoholic hepatitis. And again, that can be part of chronicity or a part of alcoholic hepatitis. Coming to the LFT, so bilirubin is normal, and the previous session has made my work easier. So we look into the AST and ALT levels. So there is something called Ratis ratio, D-Ratis ratio we calculate, AST to ALT ratio. So that's less than 1. So less than 1 AST ALT again goes against alcoholic hepatitis. So that goes in favor of chronicity. However, high GGT can be seen in presence of alcohol abuse. So I would not put it as alcoholic hepatitis. Possibly he has some chronicity features on CBC with low platelets, high INR, and AST D-Ratis ratio less than 1. And with a high GGT, maybe a chronic liver disease with alcohol abuse related some hepatitis.
Dr. Agarwal.
Yeah, I think so. The GGT is a marker of alcohol consumption.
Exactly.
So I think that explains it. The SGPT is more than the SGOT, so that's a little bit against the liver damage being primarily due to alcohol.
Two things going on there, probably.
I think you should also take a good drug history in this patient. He had a road traffic accident bedridden, may have had a lot of NSAIDs and other medications.
But talking to
And
the
that's
family,
also
they
a possibility.
said some amount of paracetamol, but nothing else, because it was a minor, you know, like motorcycle accident. So he didn't take any painkillers. I took a history.
Okay. I'm not sure about this
NSAIDs.
platelet of 1,47,000 as being really abnormal. I mean, we see a lot of people in this part of the country, many of them have a platelet count normally like this. So I won't put too much on that. Even an INR of 1.2, I mean.
Yeah, 1.2 I'm
okay.
not worried about.
Yeah. So wouldn't give any much importance. I would not think of a chronic liver disease just based on that platelet value or the INR.
Anybody from the audience, they have any comments? Anyone? No. Probably alcoholic liver disease, probably hepatitis is, though he was not jaundice, but just the amount of alcohol they were telling me. But the wife was saying that in the past, though he was saying he takes 120 ml, he tends to drink a lot more, binge drinking. So we got the lipid profile done. His triglycerides and cholesterol were high. LDL was high at 151. We got an ultrasound upper abdomen done, which showed a liver 16 centimeters. Echo was raised. And though his portal vein and spleen was completely normal, that rules out chronic liver disease, no ascites. And a grade 2 fatty liver with hepatomegaly was reported. I tried to get a fibroscan of his liver done, but at that time they were in a rush to go back because they came from another city, so they didn't get it done. So, Dr. Roy, what do you think is going on now?
So, first of all, I agree that this is not alcoholic hepatitis
Yeah,
per se by definition. This would at max be alcohol use disorder.
Abuse disorder.
With the recent abuse with drink. So what we are having here possibly are two things. So if you break it down, I saw the fasting sugars, that's 105. And now you've got abnormalities in lipid profile. Your triglycerides are high, cholesterols are high. Your non-HDL cholesterols are also high. Your LDLs are also high. With that, you've got somebody who's having some alcohol use. So if you put it together into the current classification of steatotic liver disease, do you have fat? Yes, as shown in the ultrasound. Do you have cardiometabolic risk factors? You have two already out here. I think the BMI is also high. So you have diabetes, more than 100, I think that's the criteria. You've got high TGs, HDL is not low according to this criteria. And secondly, you have got another cause of associated fatty liver. So that they give it a specific entity out there, which will be MET-ALD. So you've got metabolic dysfunction, plus a component of alcoholic liver disease. I would have loved to see something like an MCV. There's a score which comes out of Mayo called the ANI score, alcohol, non-alcohol index, which basically divides between alcohol use and non-alcohol use. It's a good score to sort of differentiate.
His MCV is normal, that is why I've not put it here.
Huh?
His MCV was normal, that is
MCV was normal.
That is why I've not put it here.
That goes a little against a long duration significant alcohol use. And GGT can be raised in NAFLD also. We see some of the highest GGTs in patients with NASH. So this is possibly MET-ALD, that subgroup.
So I just want to go through the grades of fatty liver for the for audience here. So grade 1 is when we get reports of grade 1, it means that the echogenicity of the liver is high in comparison to the spleen and right kidney. Grade 2 moderate is blurring of the intravascular structures, and grade 3 is deep attenuation of ultrasound signal, and the diaphragm at the posterior surface of the liver cannot be figured out separately. So this is how they say grade 1, 2, and 3. And like we were talking about the metabolic syndrome, you require presence of 3 or more out of 5 criteria. Waist circumference is different for Indians. I'll show you that separately. Triglyceride level above 150, which is here in this patient. HDL less than 40 in men. But this guy had 50. Now I was reading up that if you drink alcohol, your HDL goes up. So when you actually take out alcohol from the equation, then actually it falls, like we'll see later on. Systolic BP, 133 our patient had, and plasma glucose levels were sort of normal. And this is for Indian BMI for Indians. Normal is 18 to 20, sort of 3, and our patient was nearly 28, so obesity, he falls in the third criteria. And the waist circumference for Indians is more than 90 centimeters in males and more than 80 centimeters for females. So our patient was 96. So sort of he falls into the metabolic syndrome criteria. And so I calculated his APRI. Now this was very confusing for me because the APRI was 2. So above 1 is severe fibrosis. NAFLD score showed minus 1.58, so that is not significant fibrosis. And then you have a FIB4, which is 1.85, which again shows a fibrosis stage of 2 to 3. So with all these values, it was more confusing because I'm not sure whether the patient has got significant fibrosis above F2 or not. So Dr. Bohidar, what would you do with this patient? Because all the three values, especially FIB4 and APRI, which we tend to use and which is also recommended by INASL, there's a discordance between them. So would you use NITs regularly for your patients, and what would you do in this patient?
It depends upon the availability of other methods. At NITs, these are usually easy to access, and though we do not find much time to do it regularly, I wish everybody should do.
What about you, Dr. Mukherjee?
I think according to our INASL guidelines, we would be using the APRI and FIB4 at least.
Yes.
Because they would rule out the next stage of your investigations. If definitely you have somebody with a APRI low score and a FIB4 low score, then say APRI less than 0.45, FIB4 less than 1, you would probably give them lifestyle advice, not proceed any further. And if you had values above that, like FIB4 greater than 1.45 and APRI greater than 0.67, you would go ahead and get a fibroscan done for this patient and stratify them into the 3 groups. At least that is the latest INASL guidelines say.
Yeah, but this patient did not get his fibroscan done, so we are left with these scores. Because
Yeah,
I
mean,
asked him to get it done.
because there is a discordance between your FIB4 and your NAFL
scores.
You would like to get a next stage of your investigation, whatever is available at that stage. You would like to ideally get a fibroscan, and if you still find a discordance, you would get another thing which is gold standard. If you could get a liver biopsy, yes, or you get a MRI for
MRI elastogram.
Yeah, MRI.
So just want to go through this. APRI 0.5 or less sort of rules out significant fibrosis. FIB4 less than 1.3 and NFLD fibrosis score less than 1.455. So our patient, his NFS score was less than minus 1.45, but APRI and FIB4 were both in favor of significant fibrosis.
Ma'am, I have a comment. Regarding the these test, APRI, FIB4, FS, we can use some combinations, and more so in this patient because he is already in hepatitis stage. So enzymes were of the order of 200 or more than 200. So maybe a fibroscan may not give you a very correct reading in this case. So fibroscan, in fact, may not be correct in this case. So we cannot rule out a moderate grade of fibrosis in this. APRI is more than 2, so like APRI, if it is more than 2, ma'am, it rules in a severe fibrosis because it is a high value for ruling out a severe fibrosis over and above FIB4 and NFS. So if once we get a APRI value more than 10, more than 2, so it rules in a severe fibrosis. So at this stage, the patient, maybe APRI was the better modality because fibroscan would not have helped in this case, or you go for a liver biopsy.
Anyway,
so liver is enlarged and inflamed, so
I agree
possibly.
with you because some patients we get very high readings on fibroscan if they have abnormal liver
so
function.
the more the hepatitis, ma'am, the higher the fibroscan value will be.
So anyone from the audience has any comments on this till now? Yes?
Speak loudly.
Dr. Arya from Jamshedpur. Very well presented, madam, but only one thing just I wanted to comment in this, that a patient having blood sugar fasting around 105 and HbA1 is only 5.4, so we cannot label this patient as a diabetic patient. As it was mentioned by sir, we cannot label a patient having fasting around 104, 105 and HbA1c 5.4. In any way, we cannot label such patients as a diabetic patient.
No, I have not labeled this patient as diabetic. He's just
Yeah.
giving his opinion. I would not label him as diabetic. he just has
It's
metabolic
not for
syndrome.
labeling as diabetic.
Yeah.
I absolutely agree on that.
Yeah.
This is the criteria that has been put forward for metabolic dysfunction in the definition of NAFL. We are not labeling this patient as diabetic or non-diabetic. It's a criteria for labeling metabolic dysfunction. And I agree with you on that. I think there's a beautiful paper that's come out of Serge group who have compared when you use the ATP3 vis-a-vis the current criteria, you're actually sort of bringing a whole large amount of population and calling them metabolic dysfunction. So these are absolutely well pointed and this needs to be taken into account.
Thank you.
So the patient does not have diabetes, it's just the metabolic syndrome criteria. So for us to make a NAFL diagnosis, the alcohol intake, our INASL guidelines say less than 20 grams both for men and women, but the ASLD guidelines are a little kinder for the men. They are saying 30 grams for men and 20 for women. So obviously, this patient was drinking much, much more. Management, I gave him a PPI because he was not eating and drinking a lot of alcohol. No alcohol at all, we told him to eat 4 hourly and to drink plenty of fluids. And because I thought he had GERD, so no lying down after meals for 1 hour. Less red meat because I think he owned a restaurant, he just ate too much red meat also. Oil, fat and diet, and to walk 5 kilometers daily to reduce 2 kilos of weight because his BMI is quite high. And I've actually given him pentoxifalin because of his alcohol intake. According to the wife, he was drinking a lot. We can debate on that, but I like this drug, so I gave him pentoxifalin. We gave him vitamin A, 800 milligrams per day, and also saroglitazar. His target weight was at least to lose 10% of his weight over a period of 6 to 8 months. He was deficient in vitamin D and vitamin B12 both, so I gave him supplements and I asked him to see me in 6 weeks. So would you agree with this, Dr. Prakash?
Ma'am, regarding pentoxifylline,
Can you just be a bit louder?
Ma'am, regarding the pentoxifylline use, so if that was for fatty liver, maybe we can go ahead. But alcoholic hepatitis, since we are not labeling the patient, and also, ma'am, it definitely is beneficial, but it has not seemed to be beneficial in the trials. So if going by the trials, maybe for alcoholic hepatitis, we may not prescribe that. Vitamin E, if the patient already has cirrhosis, I don't know if I can give to a cirrhotic patient vitamin E, the dosage maybe, and saroglitazar also, I don't know if I can give in cirrhotic patients. Although we have a trial by Sir only that saroglitazar was safer in cirrhotic patients. And regarding weight loss, definitely, ma'am, we'll go for a weight loss. Vitamin D and B12, not without reports. If there is a deficiency,
He had deficiency on his reports,
yeah,
we gave it to him.
so if the patient has deficient, we would go ahead with that. So regarding, maybe I would go for some SAMI addition, which might help the patient, pentoxifylline, if we are thinking the patient is having severe hepatitis in fatty liver, there are trials going on, so maybe pentoxifylline in that regards, but not for alcoholic hepatitis. E in cirrhotic patient, maybe I'll not give, ma'am, with grade 4 fibrosis.
What about Dr. Agarwal? What would you say?
Regarding the fatty liver patients who come to me, at least I am a little bit thrifty in prescribing drugs to them because I believe that the treatment of NAFLD is actually lifestyle modification. And that is why you need to spend a little bit of time with the patient and actually explain what that means. How is he going to lose this weight? It's actually the refined sugars which have to go off completely. It's not just fat and other things. And you also have to stress that there should be adequate protein in the diet. You have to give them a target, like you said, say 2 kgs in a month is a reasonable weight loss. It's not difficult to achieve. And total calorie restriction. After that, I personally don't think, there's much evidence that a cocktail of drugs actually helps in improving things faster. I think it is the weight loss which has to be achieved. He's 166 kgs, so my target would be about, his ideal body weight is about 66 kgs. Height in centimeters minus 100.
His height was 166, so his ideal weight was less than 60 actually.
No. It's height in centimeters minus 100. That's the ideal body weight, roughly. So target weight would be about 66 kgs. And if at all I had to use a drug out of those 3, I would preferably use saroglitazar because I have got a little bit of experience with that. And there's some evidence that it actually works in different stages of fibrosis also, even in the little advanced stage as well as in the lower stages of fibrosis, there's some evidence that it is working. So I would just use one drug if at all.
Okay.
And initially, maybe when the enzymes are a little high, sometimes we do use UDCA just in that phase. But probably saroglitazole may also normalize the enzymes.
Okay.
So I would not use anything else. Yeah.
Anyone from the audience? Do you have any comments? No? Yes. No, here we were giving it for the NASH. For the NASH. No, it has been approved for NASH patients in India. It's not off-label.
And that is also borderline, your triglyceride and...
If you look at the
this thing,
APRI and the
200
FIB4, they were high at that time.
I am agree with that,
Yeah.
sir.
No,
that
actually, see,
there is no use of drug in this case. Lifestyle modification and weight reduce will do.
Saroglitazar initially came into light because of high triglycerides. Diabetic patients, it helps in decreasing of triglycerides also and control of sugars also by its actions. So in this case, maybe if there is no cirrhosis, I would use saroglitazar if he has advanced fibrosis only in light of the metabolic factors and also the high triglycerides. And maybe fasting sugars, just borderline sugars, so it would help in everything. If he is the advanced fibrosis, but if he is in cirrhotic stage, maybe I would not use saroglitazar.
So just want you to take a look at this, that the ASLD guidelines say that if your patient is drinking alcohol and you think the patient has NAFLD, then they should completely be off alcohol, because that also is a cofactor for liver disease progression. So we should assess the intake, and then usually we should ask the patients to abstain. Because if they have significant fibrosis, which our APRI and our FIB4 are suggesting, then we should take our patients completely off alcohol. Because it decreases then the fibrosis progression. And weight loss, it is a combination of, like we were talking about, hypocaloric diet and increased physical activity. Regular exercise will improve the insulin resistance and decrease the cardiovascular risk. And the target weight loss is 7 to 10 months and 6 to 8 months. So for overweight patients, 7, and for obese patients, 10%. And we do know that as little as 3 to 5% weight loss will decrease the steatosis, 7% will decrease the steatohepatitis, and 10% will decrease your fibrosis. And for the calorie restriction, at least 30%. So we're reducing 500 to 1,000 kilocalories per day.
Deepika, we need to hasten things. We are short of time.
Time is over? Okay.
Yeah, I think 2 more.
Pardon?
2 more minutes,
Okay.
3 more minutes
so the
left.
INASL guidelines
we
for
have to wind up with
exercise
the
is
comments.
moderate intensity aerobic or resistance exercise, 30 to 45 minutes per day, at least 5 days a week, irrespective of body weight, and resistance exercise for patients who can't do aerobic exercises, and role of yoga is quite underexplored. So I'm just going to go through the follow-up visit. He did lose 4.8 kilos, and his BMI has come down to 26.2, and his blood pressure and his pulse was better, so was his liver span. And if you look at the AST and ALTs, ALT is back to normal, gamma GT is better, AST is better, and platelet is slightly up. And though his triglyceride, cholesterol all went up now. So we can see that the moment he stopped drinking alcohol, he did not drink any alcohol. He came to me after 3 months. His HDL is now gone down, and triglyceride, cholesterol is really high up. So I think he was eating a lot of red meat because he owns a restaurant, but he was walking, so I think he lost the weight because of that.
The clue is in your first slide. He's from Tripura. I belong to the same place. They eat 4 times rice out there, along with some occult alcohol use, which they'll never tell you. So this is possibly out of that, this TG. Or the other thing is that you gave him saroglitazar. His TGs were going down, and there's a rebound increase. I don't know what the data is on that whether you stop saroglitazar, you might have a rebound increase your triglycerides. Additionally, I will also look for other causes of hypertriglyceridemia. But this for me is either his diet, his staple diet, maybe some occult consumption of alcohol, and a rebound possibly post-saroglitazar.
So he got his fibroscan done, and surprisingly, his stiffness was only 6.2. CAP score was also S0, but if he calculated his APRI and FIB4, it wasn't, FIB4 is also 2.35. So
Yes, sir.
There's a discordance between the FibroScan and the FIB4 and the APRI.
Yeah, so because ma'am, APRI, FIB4 and FLD go hand in hand. There is a decrease in fibrosis compared to the previous. He has stopped alcohol, maybe the inflammation has decreased also. FibroScan in few of the cases, ma'am, is not representative of the area in which FibroScan has been done because there is no uniformity. If there is any doubt, we can go for MRPDF. If there is doubt, which can give a picture of the entire liver. But a non-representative phase can be there. And also APRI is not very significant, maybe 2, 3. So FibroScan around 7 to 3. We don't have the IQR values of the FibroScan taken. Whether it was taken correctly, we don't know the quality of study. So we need the IQR study of the FibroScan to see whether it was done correctly or not.
So they weren't very keen to get an MR done at that time. So I just want to take you through that more than F2, if we are looking at 8.2, F3 9.7 and F4 for 13.6 kPa. So our patient had 6.2, so he did not have significant fibrosis. And so I told him to not take alcohol again, continue walking, stop red meat. And because his triglycerides level are nearly touching 500, I asked his other family members like brothers and sisters also to check. He stopped vitamin E because it did not agree with him, and we added atorvastatin and ezetimibe. I asked him to repeat his LFTs and lipid profile in 3 months, and to get an MR elastography as well as a vaccination against hepatitis A and B because he hadn't got it done before. Now, I've just done a video consultation with him
Deepika,
on the 7th.
Please wind up the case. We are short of time. Please wind.
Okay.
Please finish,
So
and
now
we'll have one question.
he's
After
not-
that, comments and end.
So this is his latest BMI. It is around 26.49, and APRI, FIB4 have all come down, and NAFL score is also better. So just quickly, he's walking now. We've stopped most of his drugs. He's only on atorvastatin and ezetimibe. And next time when he comes to Kolkata, we've asked him to get an MR elastography done also. So quickly, with your NAFLD risk factors, obviously we know obesity, type 2 diabetes, and dyslipidemia. And metabolic syndrome is associated, but you have polycystic ovary disease, hypothyroidism, obstructive sleep apnea, and hypopituitarism, which is also emerging association. And incidence in our country, latest paper by Dr. Shalimar et al., they have shown that it's 38.6% for adults and 35.4% children, which is very alarming in our country. And we have, our population is now at least 1,420 million, in which 72.5 million are diabetic. So more than 35 million patients will have NAFLD. Patients of diabetes will have probably NAFLD because we have found out that 56.5% of our diabetics have NAFLD. So it's a huge number of patients which are going to come to us. And most of our patients do have insulin resistance. This is the INASL NAFL guidelines which Dr. Prakash was talking about the FIB4 and APRI. If they're above 1, FIB4 and APRI above 0.45, then we have to get the FibroScan done. If they're less than that, we can just watch them, and then according to the FibroScan,
Deepika,
get the
we'll be
test
closing
done.
this session now. I'm sorry. We
Okay,
have to close this session.
So take-home messages is NAFLD and NASH is very common in India. It is becoming the common cause of liver transplant in our country. So we need to think about it in every obese, hypertensive, diabetic patients, also ischemic heart disease. Investigate if the ultrasound abdomen shows fatty liver. Please don't tell the patient it's nothing to worry about. Encourage patients to lose weight. That is the easiest for the patient to do by decreasing calories in the diet. Diet always plays a bigger role than exercise. Counsel them regularly. Regular follow-up in clinic. If they have dyslipidemia, please treat with statins. And we have drugs like vitamin E, pioglitazone, seroglitazole, and pentoxifylline. I do not give ursodeoxycholic acid because it normalizes your liver function test. Then the patients are only worried about the abnormal liver function test. Then they don't exercise. FibroScan is easily available in our country, so please refer. MR elastography is quite expensive. Most of the patients cannot afford it. But if they can afford, then it confirms the fibrosis stage better. Encourage patients to not drink alcohol if they have significant fibrosis, or at least decrease the amount. Vaccinate. If they have cirrhosis, obviously we need to get the ultrasound and the alpha-fetoprotein done every 6 months. And work as a team with your endocrinologist and cardiologist. And remember that all our NASH patients eventually will die with liver-related deaths, but will have more cardiovascular problems earlier and even CKD. So we need to refer our patients to transplant center. Thank you.
Thank you, Deepika. That was an excellent presentation, but Due to shortage of time, we cannot have any further questions. I'll give only 2 comments before I wind off. Number one, we have a recent publication. It's multi-centric from different centers all over Asia, which clearly showed that all of these, in spite of the INASL guidelines we have had, all these so-called NITs, they don't work well in Asians. They have not been validated in Asians, all the criteria. That's very important. Second thing is, it has not yet been shown that when you are trying to follow these NITs, improvement in NITs as a sort of marker for your improvement in they do not correlate with improvement in quality of life or with outcome. This is the other thing. Zonosi's paper published a couple of years ago has shown. So we are not sure what use these NITs are in clinical practice, except that they are very important for generating patients for drug trials. When you are thinking of generating patients for drug trials, they are okay. But in routine practice, whether they are of any use or not, we are not sure. With these, I thank Deepika. Thank you, Deepika. And I thank my co-chairperson and all the panelists for a wonderful session we have had. Thank you. Thank you all.
So we move on to session 3. Session 3 is compensated cirrhosis, and that's again an area which sees a lot of advances both in nomenclature and classifications. For this session, I would like to call upon the chairpersons, Professor Manisha Dwivedi ma'am. She was the head of gastroenterology and hepatology and now at Dwivedi Multispeciality Hospitals, and she's the ex-head of the department at MLN Medical College, Allahabad. And Dr. Swayambhu Banerjee, who is a consultant gastroenterologist and hepatologist at Bankura Seva Nikatan Hospitals. And could I please call upon sir to take on the session on compensated cirrhosis from here.
Good evening, everybody. The next session is how to diagnose and manage a patient with compensated liver disease. And may I call the panelists for the session, Dr. Saptrishi Vishnu. He's a consultant gastroenterologist and hepatologist at Astha Medical Center, Bardhaman. Dr. Kaushik Chatterjee, senior consultant, Department of Gastroenterology at Peerless Hospitals, Kolkata. Dr. Souvik Ghosh, an associate professor, Department of Gastroenterology at Calcutta Medical College, and Dr. J.R. Mahapatra, who is a senior consultant, Department of Gastroenterology at Peerless Hospitals, Calcutta. And it's our privilege to have Dr. Kamath, who will navigate you through the case and dispel your doubts. Dr. Kamath, please.
Can you hear me now at the back? Yes? Okay, good. Thank you. Thank you, Deepika, because part of what I'm going to be speaking will overlap with what you have said. So if you have time, go to this NASA site which shows the world with these new telescopes. With the James Webb telescope, you get spectacular images. So this is called the Small Magellanic Cloud. And this is a picture which has come from that. And so I think the future of hepatology is very bright because you can see it in the stars, okay? So patients with chronic liver disease get cirrhosis, and when they get jaundice, ascites, variceal bleed, hepatic encephalopathy, that is decompensated cirrhosis. Now, in any one of these situations, there are precipitating events, viruses, drugs, but alcohol very commonly. In any of these situations...
Excuse me, Dr. Kamath, please. Can we just increase the volume? You're not clearly audible here.
Okay, let me try and speak a little. So in any of these situations, can you hear me at the back? Yeah. You can get combination of hepatic and extrahepatic organ failures, and this is acute on chronic liver failure. So the first take-home message is institute prevention in all patients with chronic liver disease. So again, show of audience. So compensated cirrhosis, patient has compensated cirrhosis. Which of these physical signs will you see? Spider nevi, hands, caput medusae, palmar erythema, parotid enlargement, deputant contracture, panel, or none of the above?
I think all can be there.
Not none of the above. So usually in compensated cirrhosis, this is the asymptomatic phase. You don't see any signs. That's why it's important for all these tests that we have. Typically in 60 to 70%, the first manifestation of decompensation is ascites, okay? So in this talk, we'll go over what is compensated cirrhosis. It's the asymptomatic phase of cirrhosis. Typically, you'll diagnose it in the follow-up of thrombocytopenia or elevated liver tests. And again, as Deepika told you, it's in the obese patient, diabetes, alcohol use. Suspect this patient might have cirrhosis if they have thrombocytopenia. The peripheral signs of cirrhosis are typically absent in these patients. And death in the compensated phase is from cardiac disease or cancer. And again, like I said, usually the first manifestation of hepatic decompensation is ascites. Okay, so in this talk, let's go over first. How do you diagnose cirrhosis? Because this is often difficult. Preventing hepatic decompensation, what can you do? Determining prognosis, immunizations, which drugs can you use safely? Little about hepatocellular carcinoma surveillance, and then some take-home messages. Okay, so methods of fibrosis estimation, you have serum biomarkers and you have imaging. So you can use them independently or sequentially depending on availability. Okay, let's come into this, and this is for the panel. I know there are no commercial biomarkers available in India, at least I don't think they are. Do you think we should get commercial biomarkers? Do you think they're better than FIB4? Second question is, transient elastography examines 100 milliliters of the liver. How much does it examine? And MRE examines 100 milliliters of the liver. Let's take one by one. Do you think we need commercial biomarkers? Or is FIB4 good enough as screening?
FIB4 is better than commercial biomarker.
Good. Ultrasound elastography. How much of the liver will it examine?
Sir, is it the shear wave elastography or transient elastography?
Transient elastography.
It's transient elastography. Yes, 100 ml liver.
Okay, so a lot of the liver. And MRE?
It's much more. Your entire liver.
100% of the liver. Okay, let's go with that. So generally, this is the performance of biomarkers, and what I want to show you, the commercial tests are very expensive. I know the drug company will are trying to push it in India, and they're very expensive, but they don't really add on too much here, okay? So FIB4 is good, and I like the INASL guidelines focusing on FIB4. So these are the limitations of transient elastography. So remember, it has to be 2.5 centimeters from the liver. So if the patient is obese or the patient has ascites, the accuracy is going to decrease. The volume explored is very small, 4 centimeters by 1 centimeter. So the volume of fluid of liver is only 3 to 5 milliliters. It's very small volume, that is. And based on transient elastography, we have normal, we have fibrosis, cirrhosis greater than 12, and clinically significant portal hypertension, typically greater than 15. So this is how you will interpret transient elastography. Now you go to MR elastography. This was invented by one of my colleagues, Dick Eman. So basically it's sound. If sound goes to the liver very rapidly, that means like this. Anything stiff, sound waves go very quickly. Anything soft, they go very slowly. So the MR and elastography is checking how fast the sound waves are going through the liver, okay? And then you generate an image like this, and you can see violet, indigo, blue is a soft liver. Starting to green is fibrosis, and yellow, orange, reds, that is a cirrhotic liver, very stiff. So typically, you take slices on MR elastography, and it picks up about 250 milliliters of the liver. One advantage of MR elastography, it's much more expensive. You don't have to use it, but much more expensive. But the advantage is you can get good orientation. So when you do an elastogram, you don't get orientation. Here you can get orientation, and you can see regional differences in stiffness, okay? And this is how you interpret it. Less than 2.9 is normal. 3 to 4.9, fibrosis. Typically, you don't require a biopsy. Greater than 5. So this is a problem. Sometimes you do it, and you had not suspected cirrhosis at all. Platelets are okay, and this shows greater than 5. Don't make a diagnosis of cirrhosis. You need a liver biopsy here to confirm. But if your suspicion of cirrhosis is high, then you don't need a liver biopsy. Okay, so this is how you interpret MRE. But both MRE and fibroscan may be inaccurate if it's postprandial. In obese patients, alcohol, lot of inflammation, inexperience, and remember, in cardiac disease. So you must know which group of patients you're actually going to do the procedure in. So this is for you, your message. When will you diagnose cirrhosis? Patient has chronic liver disease, comes with varicella hemorrhage, ascites, or hepatic encephalopathy. That is usually enough for you. Don't need a liver biopsy, this patient has cirrhosis. Does not have complications. When you examine the patient, splenomegaly, some stigmata of chronic liver disease, thrombocytopenia. If the patient has that, again, no need for liver biopsy. That's good enough for you to make a diagnosis of cirrhosis. If they don't have these physical findings and laboratory findings, look on imaging. If you find splenomegaly, ascites, collaterals, that is again good enough. You don't need a liver biopsy. But if they don't have all this and your suspicion of cirrhosis is high, then you require a liver biopsy. So this is another take-home message for you. Evaluate these patients. You don't require a liver biopsy. In most patients, you can make a diagnosis of cirrhosis. Okay. So now that you've diagnosed cirrhosis, the next is you prevent hepatic decompensation. So, if you lose weight, what are the advantages? Less risk of decompensation, show of hands, yes or no? 1, 2, 10, okay. Lowers portal pressure? Good. What do you think?
Definitely lower the portal pressure.
Good. Deepika, let's see if they listen to you. How much weight should you lose to reduce steatosis? 3%? I hope you remember the last talk. 5%? 7? 10? Lose steatosis. Oh, 10 you'll definitely lose. What do you think?
3 to 5% reduction.
Good. Okay. So preventing hepatic decompensation, most important, you've diagnosed cirrhosis, treat the cause. Irrespective of what the cause is. They can have hepatitis C or hepatitis B, no alcohol, make them lose some weight. And then you treat the specific etiology. Prophylaxis against variceal bleeding. Immunizations we'll talk about. Be careful about using drugs. And let's come to weight loss, because this is general across all. This is what we know. Many studies now coming out showing that obese patients with cirrhosis, whatever the cause, will do worse than patients who are not obese. So obesity is an independent risk factor for hepatic decompensation. So make sure your patient is working on some weight loss. And if they lose weight, if they exercise regularly, you can decrease portal pressure. Okay, so you know how to diagnose cirrhosis, tell them to stop drinking. If they're overweight, make them lose some weight. But weight loss is difficult. What are you most scared of? Sharks or burgers? Who's most scared of sharks? Sharks kill 10 humans in the whole year, in the whole world. Okay, don't be scared of sharks. Burgers attack 116 million people every single day in the United States alone. Okay? So this is what is killing us. This is what you should be really scared of. Okay, question for you. Do pizzas, burgers, pasta Alfredo, and chicken sandwiches have higher calories than a good masala dosa? I'm from Bangalore. No place you get better dosas than Bangalore. So I know a good masala dosa. So what do you think has less calories? Anyone? Who says masala dosas have more calories? Anyone? One. SP. Good. So this is a really interesting study in the BMJ. They've gone across the world. So this study was from Bangalore. They've looked at restaurants in Bangalore. So Western fast foods, again from Bangalore, single serving. This was the calorie count. And what about the masala dosa? 1024. North Indian thali 1809, biryani 1464, jeera rice with chicken curry 1890. Okay, so our culture is moving towards more fat in our meals, but we'll also talk about unprocessed foods. So, weight loss, first-line therapy. Healthy choices. Our typical Indian meal is very good. Vegetarian is good. Dal, lentils, very good. Minimize refined carbohydrates, high fructose corn syrup, and ultra-processed foods. It's actually ultra-processed foods which are killing us. Add aerobic exercises, some muscle. The problem with Asians, South Asians, is not only are we overweight, we have less muscle. We have sarcopenic obesity. That combination is bad. Get them to build some muscle. We don't know which exercise works best, but 150 minutes of exercise per week for everyone. But lifestyle changes, most people don't want. Pills and surgery is what most people are thinking of doing. And, there are drugs which are coming out. So here's what we know about weight loss. If you exercise 150 minutes a week, or lose 3% weight, you will lose fat in the liver. 5% you start losing ballooning, 7% the inflammation is going away, and 10% you start losing fibrosis. So patient has cirrhosis, aim for 10% weight loss, maybe you'll get 5%. So no alcohol, lose weight, prophylaxis against variceal bleeding. So here is where you send your patient to someone on the panel or in the first 2 rows. Endoscopy shows no varices. When will you repeat? When will you repeat the endoscopy?
No, there is no need of, we have to see for the clinical significant portal hypertension.
We'll get to that in a bit. But
by transient elastography as well as the platelet count, and if it is 15 to 20 and the platelet count is normal, then we should not go for the surveillance endoscopy.
Good. So I actually want to follow up what you said, SP Singh. India, China, and Africa account for 45% of the world population. We are told how to treat patients based on small countries out in the West. The studies are done there. I think a lot of this has to be validated in India. I don't believe we have studies. We have huge populations we can study. I agree, SP. NITs have to be validated here. We know they're not good for population screening, and so they have to be done in here. So no varices. We'll repeat endoscopy in 3 years. Small varices, red signs, no red signs, repeat endoscopy in 1 to 2 years. If they have red signs, then a beta blocker. Which beta blocker do you use?
Either propranolol or carvedilol.
Which one?
Propranolol.
Propranolol, yeah. So again, the carvedilol data has to be validated outside. No, but propranolol is reasonable. I think on the West, they've shown carvedilol is better. I think we need some validation of those studies here. So titrate beta blockers, resting heart rate less than 55 or 25% from baseline. And if they have medium to large varices, beta blockers, okay? But generally, if you have a patient with low, like you said, low liver stiffness, platelet counts normal, you probably don't even need to do endoscopy in these patients.
Sir, I have a question, sir. Sir, if the medium or large varices, does it help the EVL as the primary prophylaxis? Because NSB, non-selective beta blockers, not only reduces the varices size, it also reduces the chance of development of ascites.
So you're talking because
primary prophylaxis, sir.
No, because I'm hearing the echo there. Maybe without a mic, can you try?
I can, sir.
Sir, primary prophylaxis.
Yeah.
NS non-selective beta blocker is better than EVL or not? Because sir, NSB is reducing the chance of development of ascites also.
Sure. So the good question. Actually, I can hear much better without the microphone. I can hear a lot of. So the question here is beta blockers or ligation. So beta blockers, if you take the risk of reducing bleeding, same for both, no difference. If you look at all-cause mortality and decompensation, beta blockers slightly better. I think all of these have to be discussed with the patient. Remember that endoscopic ligation, more expensive patient has to come back, but don't have the complications of beta blockers. You know, younger people, especially younger males, do not like beta blockers. There's erectile dysfunction with that. So we always discuss that with the patient instead of using the same thing for everyone. Try not to use one treatment for everyone. Talk to the patient, let them decide which one of the two. So I always talk to the patient. I say, this is the advantage of each one of these. You pick whichever one. Okay, now prognosis. Most common cause of death in patients with cirrhosis, compensated cirrhosis. Show of hands, variceal bleed, HCC, hepatic encephalopathy, cardiovascular. Good. So it's cardiovascular. Remember, in compensated disease, they're not dying of liver disease, they're dying of cardiovascular disease. So institute cardiovascular prevention. Patients with compensated cirrhosis are going to do well for some time, so you have many years to work on them. So that is the reason why you try and get them to lose weight. So median survival is 9 to 12 years. It's probably even longer now that we are picking up patients much earlier. Deaths, compensated phase is non-liver related. It's cardiovascular or malignancy. When do you suspect the patient is getting decompensated? There are pressure measurements. You can look at the MELD score slowly going up, albumin dropping. These are patients who are going to do worse. Maybe see them at 6 months instead of seeing them every year. Then immunizations. Make sure you have some immunizations. Which do you think is contraindicated in cirrhosis? MMR? Typhoid? Typhoid? Oral polio? BCG? None of the above? Good. Panel, what do you think? Good. So immunizations in cirrhosis are safe. Make sure everyone in cirrhosis gets a COVID vaccine, pneumococcal, influenza, and tetanus. These recommendations are from the West. There are no recommendations for this in developing countries. Hepatitis A and B vaccine. This is just for me. I know the government instituted in India hepatitis B. Maybe you can help me, Avijit. Instituted hepatitis B, they said at birth, if it's institutional, 6 weeks and 14 weeks. That's with the goal of getting 90%. In the 10 states, it wasn't going so well before. Is it better now? Are we getting universal, almost universal vaccination of getting? Yes, we're getting it. Is it? Okay, good. Because then you don't have to worry about that. Remember, if you give them vaccines late in the disease, it doesn't work. So once you diagnose cirrhosis, make sure they get their vaccines. Live attenuated vaccines, those are contraindicated post-transplant. But otherwise, you can use any vaccine in these patients. So another take-home message, vaccinate early stages of cirrhosis. Then drugs. Okay, what about statins and cirrhosis? Patient has cirrhosis and statins. Who wants to use statins? Who's worried? Good. Statins, extremely safe drugs, okay? So you can use them in child's age cirrhosis. That's all we know for now. So that these are studies which have been done showing that statins are safe. So child's age cirrhosis, not a contraindication. The question is, what if they have got decompensated cirrhosis? If they're on a statin, we will continue. If they're not on a statin, we won't start it, because decompensated cirrhosis means their outcome is going to be poor anyway. And we know with higher doses of statins, so this is the only study, simvastatin at 20 was safe, 40 had increased risk of rhabdomyolysis. So use statins. Okay, which drugs will you use? Let's start from the panel. Pain. Patients have a lot of pain. Which one do you want to use?
Paracetamol.
Good. Inflammation. If they've got arthritis, a lot of them have arthritis. Which one do you want to use for inflammation?
Again, paracetamol.
That'll help pain, but inflammation. Because these are issues. Remember, these are big issues you're going to be dealing with, and especially as physicians. What are you using? Patient has arthritis and cirrhosis. Which one are you using? If they have ascites, you have a problem. If you have ascites, you cannot use non-steroidals. That's when you have to move towards steroids. But otherwise, if they don't have ascites, you can still use non-steroidals in them. Remember, they have a lot of pain. You need to give them relief in that. Which antibiotics do you use? Which is your preferred antibiotic?
For which, what therapy?
Generally, which groups? Which ones? Which antibiotics do you think are safe in cirrhosis? No antibiotics?
Quinolones?
Quinolones are good. So remember antibiotics. We'll talk about them. Do you want to use insulin or oral hypoglycemics? Your physician's patient has diabetes and cirrhosis. Do you want to use insulin or oral hypoglycemics? Which one?
Oral hypoglycemics can be
Good.
given.
You know, these are simple things. So let's go over pharmacotherapy. Paracetamol, okay. Try and keep the dose less than 2 grams daily. If you have decompensated cirrhosis, avoid non-steroidals and aspirin. If they've got compensated cirrhosis, you can still use non-steroidals. Antibiotics, generally the ones which are good, no problem with the liver, fluoroquinolones, penicillin, cephalosporins. Again, we know some of them have idiosyncratic reactions, but generally they should be okay. Statins, acceptable. Oral hypoglycemics, if it's compensated. You move to insulin when they're decompensated because then they get hypoglycemics. You have to adjust the dose. Well, HCC surveillance. Who should undergo HCC? Maybe we'll ask the panel. This is for you. Which?
A.
All patients. What about if you have a family history of HCC? You don't want to do surveillance in them? Hepatitis B?
Sir, all the options actually.
Actually, all. A means the all option.
You're doing all. And A for all.
Actually, all options.
And A also, all cirrhosis, irrespective of child class. So if they've got ascites.
D is also there. HBV is the chronic hepatitis.
So all the options actually. So
you're saying all the above. Okay. Yeah. So this is multi-society guidelines. I've taken from all guidelines together. Patients with cirrhosis, A and B for sure. Remember the patient have ascites, encephalopathy, not a transplant candidate. Patient is dying, has got no point doing surveillance in these patients. So patients with cirrhosis, Child-Pugh class C, only if they're waiting liver transplantation. It's not a question of diagnosis, it's a question of can you change the outcome of these patients. If they don't have cirrhosis and hepatitis B, any of the following, any, ALT, AST elevated, high viral load, family history, age over 40 for men and 50 in women. So these are the multi-society guidelines for surveillance of hepatocellular carcinoma. So finally, some take-home messages, okay? Simple take-home messages here. Compensated cirrhosis, they're asymptomatic, they don't have signs of cirrhosis, so you are going to pick them up. Patient is drinking, diabetes, overweight, and thrombocytopenia. That's when you're going to suspect cirrhosis. Once you suspect that, you can make the diagnosis with the examination, look for splenomegaly. You've got some biomarkers, you have elastography, you have imaging. Use some of these to confirm your diagnosis of cirrhosis. Once you have cirrhosis, you want to prevent decompensation. So, no alcohol, lose weight, treat the cause. And don't forget, patients are at risk for cardiovascular disease and malignancy, so take care of the heart there in these patients, especially if they've got diabetes or obesity-related liver disease. Thank you. Questions?
Thank you, Dr. Kamath. That was an excellent overview of diagnosis and management of compensated cirrhosis. We can have 1 or 2 questions from the House.
Thank you, sir. So if I may ask you, what is the diagnostic accuracy or cutoffs for fibroscan in patients with CKD who are on dialysis, and sometimes the imaging shows up a suspicion of CLD? If we do the fibroscan in that patient, what will be the cutoff for?
So the question is cutoff for FibroScan. In chronic kidney disease, yes. So the question is chronic kidney disease FibroScan. First of all, it's an indication to do a FibroScan in patients with chronic kidney disease, especially if they've got diabetes. So that's a group which has a higher risk. What is the cutoff there as opposed to the rest? We don't know. We still use traditional cutoffs in those patients. But that's a population where the yield in screening is higher than the general population.
Sir, I had a doubt. You stated that you could use NSAIDs in compensated cirrhosis, but...
Do you mind without the microphone? There's
Without
a lot
the
of echo.
Sir, you stated that you could use NSAIDs in compensated cirrhosis, but if a compensated cirrhotic has esophageal varices, would you still go ahead with NSAIDs?
No. So the question here is, compensated cirrhosis, non-steroidals are safe. So the question is, if they have varices, would you still use non-steroidals? We don't do the endoscopy before each. If they've got arthritis and compensated, we use non-steroidals in them. The risk is not from erosion of the varix. Remember, there are two theories for variceal bleeding. The old theory was the erosive theory. That is, something sharp tore the varix and you bleed. The theory for past 25 years or so is the explosive theory. That is, the variceal pressure increased and that's why they exploded. So I don't think non-steroidals are a greater risk of variceal bleeding in these patients. They are a greater risk of bleeding, but not variceal bleeding.
Just want to make a comment
SP?
here. Sorry. I want to make a comment here. A lot of my cirrhotic patients want to do bench press and they want to lift weights to do exercises. And I've seen in some patients that they have very compensated child-stage cirrhosis and they've suddenly developed varices once they've done weightlifting, increasing intrathoracic pressure basically. So if they've done bench press or they've lifted heavy weights, they've actually developed varices because I think the intrathoracic pressure goes up. And the same with pranayam. People who do a lot of pranayam, cirrhotics, I think the intrathoracic pressure goes up in some of them. And, the varices sort of develop or they tend to bleed. I don't know. What do you think about these?
Yeah.
Have you experienced these patients?
So the question here is the type of exercise. Any exercise which increases intra-abdominal pressure puts you at a higher risk of bleeding. So we don't recommend bench press and all. Anything
and also
which
weightlifting.
And remember, the amount of weight lifted varies from person. We tell them any exercise where they feel the abdominal wall is tightening, they shouldn't be doing that.
And have you experienced in your practice about pranayam? I mean, though it's more, even the West is catching up with pranayam in the cirrhotics.
No,
No. Okay.
No.
Last question, Dr. Mishra.
I have one question, sir. Sir, I have one question. In compensated cirrhotic patients, in this slide it was shown that those who have small esophageal varices and those who are not having red color signs, surveillance was recommended despite not prescribing propranolol. So
maybe I'll meet you soon after. There's a lot of echo here on the mic, so I'm not hearing. Soon after the talk, I'll meet you here. I'll answer your question. I'm sorry, it's just echoing a lot with the microphone.
Sir, can I...
Last question.
Sir, I just wanted to know, in case a patient of cirrhosis, a patient of resistant hypertension, which safest antihypertensive drug he can take?
Sorry, what is the question?
He's asking about safest antihypertensive drug.
In resistant hypertension.
Oh yeah, okay, sorry. Because there's a little echo, I cannot. So the question is the safest drug, antihypertensive drug in cirrhosis. So first of all, in cirrhosis, there's a vasodilatation. So patients tend to get a lower blood pressure. So severe hypertension is typically not a problem in these patients. Beta blockers are good. So typically, if they have hypertension and varices, carvedilol is a very good drug. It takes care of the cardiac problem, takes care of hypertension, as well as takes care of portal hypertension. The problem is when we come to ACE inhibitors, the hypotension is more severe and they cause renal problems. So non-selective beta blockers are better, not cardioselective, because cardioselective do not help portal hypertension. So non-selective beta blockers, best for systemic hypertension.
Thank you.
SP, you had a question? Yeah, so the question is weight loss in cirrhotics, that they're losing weight by themselves, which is true, but actually what they're losing is muscle. So they're getting sarcopenic in there.
Thank you, Dr. Kamath. That was an excellent session. And I thank all my panelists and co-chair for this session, please.
Yeah, thank you. I'm fine. I'm perfectly okay with that too. So I just announce the sure. Will.
Just a small announcement, everybody. I see the hall is almost packed. Some of you may have left for coffee. We'll not take a coffee break. Those who are willing for a cup of coffee can stroll out, grab their cup of coffee and come back. Since the hall is full, we'll like to go ahead with the next session. The next session is on symptom management in cirrhosis, ranging from ascites to hemorrhage to hepatic encephalopathy to other symptoms. So for this session, I would like to call on the chairpersons for the session, Professor G.K. Dhali sir, Professor and Head of the Department of Gastroenterology, School of Digestive Disease, IPGMR and SSKM Hospitals, Calcutta, and Dr. Kingshuk Das sir, who is a Senior Consultant and Adjunct Associate Professor, Institute of Gastrosciences and Liver Transplant, Apollo Multispeciality Hospitals, Kolkata.
I think we thought that a lot of people will be inside, so we're going to start the session. Akash, should we give a break or we'll start? I think we'll start. Yeah, we'll start. Otherwise, we'll be delayed. Yeah, absolutely. I think this is another important session, and Dr. Patrick will come again, and we don't give him break here. It's more important for us to learn from him. We must utilize his academic experience over here. So to chair the sessions, we now request Dr. K.D. Biswas, Professor K.D. Biswas and Head Department of Gastroenterology, Calcutta Medical College, Kolkata, to come and join us on the dais. Professor K.D. Biswas. Okay, we'll have Dr. Sandeep Pal here. Dr. Sandeep Pal, Senior Consultant, Department of Gastroenterology, R.M. Tagore Hospital. Dr. Sandeep Pal is here in this hall. We request Dr. Deepika Kedia to join us here. Dr. Deepika is Senior Consultant Gastroenterologist and Hepatologist of Kothari Medical Center, Calcutta. Deepika, we three of us will try to work as a panelist. We request Dr. Patrick to start the next session. Dr. K.D. Biswas. Dr. K.D. Biswas sitting on the first row. Dr. K.D. Biswas. Are come. Okay.
So this is really the most difficult to treat in hepatology. It's managing symptoms of patients. Okay. So a liver transplant is carried out to either increase quantity of life or to improve quality of life. The problem is, in most patients, you cannot significantly improve quality of life in patients with cirrhosis. So what you have to do is try and help just a little in these patients. Remember, if you could improve quality of life significantly, then you would not require a liver transplant. So let's go over what we call health-related quality of life. How much of a problem is it in patients with cirrhosis? When you have a poor quality of life in patients, what is the impact? What are the determinants? What are the different symptoms which make their quality of life poor? And what are the different management approaches to these patients? Again, finally, some take-home messages. Okay. So generally remember, health-related quality of life has never been the primary endpoint in studies in cirrhosis. And I do think we should be having more studies looking at quality of life. Also, there's no good way of measuring quality of life because we've got limited instruments. So how much of a problem is it? So there are different ways of measuring it. There are looking at what we call generic instruments, looking at health in general, and then we've got specific instruments looking at in patients with liver disease and all. Nowadays, and if you're going to do studies in India in drugs, nowadays, at least the FDA wants patient-reported outcomes. So there's no point saying that I decrease the portal pressure. If the patient was not feeling better, then that's not a good drug. They want patient input to say that they actually felt better in these studies. So this is what we know about it. So this is the biggest problem that we have and we have not been able to solve. So if we look at people with cirrhosis, can you see, you can see here, about 2/3 cannot move about. 72% are unable to do the activities. 74% have pain. So patients with cirrhosis have a lot of symptoms. And the amount of symptoms they have is equivalent to those with advanced malignancy, not just early malignancy, advanced malignancy. So that's how sick patients with cirrhosis has. Their quality of life is half of what generally it should be. All of us hopefully have a score of 100. Patients with cirrhosis is half of that. Also, they have psychological stress. There are family worries. There's social distress, a lot of financial problems, and then when they're put on the transplant list, then they've got additional problems in there. So, huge symptom burden in cirrhosis, and that's why we have to solve them. Hepatologists are not very good at solving them. I know many of you are seeing 200 patients a day, cannot go over symptoms during that time, and that's why it's important to have palliative care in hepatology, and I hope some of you who are physicians will work on palliative care in these patients. So first of all, the patient has a poor quality of life. I told you 60–70% of them are not functioning well, but also the caregiver. So this is a study from Jazz Bajaj looking at caregivers, and you can see looking after a patient with cirrhosis is like looking after a patient with Alzheimer's disease or advanced cancer. A lot of problems, very difficult for the caregiver to function. And so the caregiver also has depression and anxiety in them because, they don't have enough support in here. So to summarize, quality of life in patients with cirrhosis is poor in the majority of patients and their caregivers too. So they have a poor quality of life. So it's important for us as physicians to try and improve that quality of life. Okay, so first it's a huge problem. So what is the impact of the poor quality of life? So this is interesting. Now we're not looking at severity of liver disease. Those who don't have a good quality of life are more likely to seek hospitalization. So there's a higher risk of hospitalization. If you improve their quality of life a little, you lower the risk of hospitalization, even if the liver disease and complications stay the same. So you have to try and make patients feel better. So not only should you treat ascites, try and work on getting their symptoms better. So this is not clear why. If you have a poor quality of life, those patients have a higher risk of mortality, independent of all the scores that we look at. So even if they're matched for the same score, they have a higher risk of mortality, higher risk of hospitalization. Okay? So poor quality of life is common, and it's associated with a higher risk of hospitalization and mortality. Okay. So what contributes to the poor quality of life? Encephalopathy makes quality of life worse. Ascites, fear of rebleeding, pruritus, fatigue, pain, cramps, and other symptoms. So in the panel, we are going to go over how are we going to treat each of these, okay? So what are the management approaches for symptom relief? As hepatologists, we want to cure the patient, so we are better at that. And initially, we start with disease-modifying therapy. But as the disease progresses, they're getting more and more problems which we cannot cure. So we are treating symptoms at that stage. And if they don't have liver transplant, then those patients are going to die. And then the family also needs some help there. Okay, so fatigue, sleep problems, muscle cramps, pruritus, pain. How do you treat fatigue? Okay. Anything else? So for fatigue, suggestions are high protein diet, exercise. Okay.
And eating regularly, like sometimes they're not taking in enough calories.
Okay. So generally, if they're tired, we look at simple things that we can treat. Anemia causes fatigue, hypothyroidism, depression is common in these patients. Hepatic encephalopathy causes fatigue, sleep apnea, the association with MASLD now. So look for a treatable cause. There are pharmacological interventions which are experimental and none of them have worked. So try and look for a treatable cause of fatigue in these patients. So there are several factors. As Deepika told you, there's muscle. The reason why people are fatigued is they have reduced muscle strength. They've got central features. Because of encephalopathy, there's poor concentration. And they have depression. So all these contribute to fatigue in the patients. So how will you treat? Very difficult to treat fatigue in these patients. So generally, reverse what you can reverse. Treat the etiology. If you treat the etiology of the liver disease, fatigue can go away. Treat anemia, hypothyroidism. If you cannot reverse, try and relieve it. Sleep. We'll talk about which medicines we use for sleep. Try and relieve pruritus, depression. And coping strategies. Patients feel very isolated when they're tired. So avoid social isolation and, as you said, nutrition and exercise. Most patients need someone to talk to. If they're by themselves, you'll see fatigue increases. So try and talk to the family about avoiding social isolation in these patients. And I think it's important because typically when they say they're fatigued, we brush them aside. But I think it's important to understand, or at least tell them you're trying to sort their problem out. So our patients are 30 years older than biological age. We know cirrhosis. So 55-year-old patient, biological age, 17.4 milliliters VO2. So at 55 years of age, how much should the VO2 be? Anyone? On the panel, how much should your VO2 be? How much oxygen should we take? It shows that you're fit. It should be about 50 or 55. So look how low it is in these patients. And 55 years, the amount of oxygen they use is like an 85-year-old. So the more oxygen you use, that shows you're more fit. Okay, so exercise them. So small studies show that if patients are given some exercise, the VO2 can increase, which means physiologically they are better and fatigue can decrease. So nutrition is important. Make them exercise regularly. That's going to feel better. So these are the results of all the randomized controlled trials in cirrhosis. Again, small and for a short period of time. Resistance training, 2 days per week. Aerobic activity, 3 to 5 days per week. So make them eat healthy. Make them exercise. What do we see? VO2 increases. The exercise tolerance improves. They feel better. Muscle mass increases, but only a little, and you can decrease portal pressure. So symptoms are a huge problem. Nutrition, exercise, okay? For all your patients with cirrhosis. And quality of life shows improvement. And with all this, exercise, their quality of life tends to be better. Among you, who exercises regularly? Show of hands. Okay. 5 days per week. How many? Good, small number. Try and make it 7. I know you don't have time, but try and make it 7. So, to summary, fatigue, the biggest problem, very difficult to sort out in these patients. And next biggest problem after fatigue, when patients complain of symptoms in cirrhosis, fatigue is the biggest problem. Second, we have no good solution. Sleep, we can give some medicine and they'll sleep. We know second biggest symptom problem in cirrhosis. What is that? Cramps, cramps, cramps. We'll talk. So first, when patients are fatigued, look for causes. Anemia, hypothyroidism, sleep apnea. Get them to exercise. Short periods of exercise. Don't give them long periods of exercise because they cannot recover. Okay, short periods of exercise. Daytime somnolence, this is experimental. Do you have modafinil in India? No? You do. It's a good drug, but you have to be very careful when you use it in here. Listen to the patient. It's important to listen to the patient. If they have itching, treat the itching, they'll sleep better, have less fatigue. Yoga seems to help. So if you have really nothing to do for fatigue, try some yoga in these patients. Next, sleep. They're not sleeping well. What drug will you use for sleep? Which one? Okay. Any other?
Lorazepam. Lorazepam.
Lorazepam, is it? Okay. See. So remember, especially with overweight patients, they have sleep apnea, and so they're sleepy during the day. Everyone says, okay, that is reversal of day-night rhythm and hepatic encephalopathy, but that's actually likely to be sleep apnea. So take a good history, find out about snoring at night. Better sleep, some suggestions. If you treat symptoms, they just sleep better. So cramps, we'll talk about pruritus, treat sleep apnea. Simple things. Don't give them furosemide at 6 or 7 in the evening. They're up the whole night. Keep diuretics first thing in the morning. No need to give it to them. Lactulose, give it to them last thing at night, so that in the morning they have a bowel movement. Don't give them an evening dose of lactulose. They'll wake up in the night to have a bowel movement. Sometimes you have to do that, but try and keep diuretics and lactulose as single doses. Avoid afternoon naps. Avoid caffeinated drinks towards the end of the day, then they won't sleep. So simple non-pharmacological. And pharmacological, there are different drugs you can try. I like trazodone in patients with alcohol-related liver disease. It's also very cheap. But you pick whichever drug you want for sleep. Make sure they sleep well. Better sleep improves quality of life in these patients. Okay? Muscle cramps. This is the problem rated by patients with cirrhosis as one no one has been able to solve for them. They have difficulty. Who has seen problems with cramping? Patients with... So what do you do?
So I have corrected sodium, potassium and magnesium and vitamin B12. If that's not worked, then vitamin E has worked at night. Or there's also one article which says pickle juice. I don't know what it is. Pickle juice.
Yeah, I know. I don't think there's any good treatment for leg cramps. I don't think there's any good drug for leg cramps either. This is what we know about muscle cramps. Cold and fatigued muscle cramps more easily. So patients will tell you the day they were doing a lot, that is the night that they will cramp more. If they work with their hands more, they get cramps in their hands more at night. So ask them to stay well covered at night. That decreases the risk of leg cramps. Baclofen and Plaquenil are the drugs that have been tried. They help. You have to be very careful about using them. And sour juices seem to help. So this is the interesting study done by Elliot Tapper. So this is pickle juice. The moment they get cramps, this is used by neurologists. Hepatologists have come into this 20 years later. Neurologists use this for cramps. Give them something sour to drink, and soon after that the leg cramps stop. So it is not because the pH changes, it is reflex, it's through vagal activity. Drink something quickly, the cramps will stop at that time. So ask them to keep something at the side in there. So tell them not to have a lot of activity towards the end of the day. Whatever activity they have should be earlier in the day, because if their muscle is very fatigued at the end of the day, it is likely to cramp. It's like any of you who've played sport, if you run a lot, that muscle is going to cramp. So avoid a lot of activity at the end of the day. Keep a little, sour juice that you want at the side in there. Stay warm at night. That will help the muscle cramps. Pruritus, another big problem. We have some solutions. What do you use for pruritus? So treat the cause, okay? Yeah.
There is no
actually, because when they use the mic, I cannot hear here. There is, yeah. Okay. So diuretics, okay. Moisturizing cream, good. So this is the most miserable patient is the one with intractable itching. They don't sleep, they're itching all the time, so they don't want to stay with others. You'll see them, they scratch so much that they start bleeding in the skin. Oh, volume, is it?
Sound, console sound.
Oh, sound, okay. So their mutilation, because they itch, they cannot focus on anything, and they get fatigued, they're not sleeping, okay? So these are things which patients talk about. So here's how you start off. Mild itching. You don't need pharmacological treatment here. Use a moisturizing cream. Remember with anything warm, so unlike for cramps, warm helps. For itching, cold helps. So if they take a hot bath, that causes vasodilatation, which increases the itching. Ask them to apply something cold. They'll even tell you if they put an ice cloth, that helps. So avoid heat, avoid hot showers. That does not help, use bile acid binders like cholestyramine. If that doesn't help, we go to drugs. Which one do you use? Anyone? SP, both the SPs, what do you use for itching? If you're using a drug and cholestyramine doesn't work? Rifampin? Yeah. So, what do you use? Rifampin. Rifampin is a good drug. What dose do you start with? 150, start at 150 and gradually increase. That's a good drug. I like sertraline too because these patients have some degree of depression too. Sertraline is a good drug in these patients in there. Then there's experimental treatment. If it still doesn't work, you can try Mars. And we also know, again, mindfulness seems to be helping in these patients. And then pain. How do you manage pain? Good. Most important, find the cause and try and fix the problem. Okay. Cannot fix the problem. What will you use? Paracetamol. Okay. That doesn't work. Because pain is a big problem in these patients. So remember, when they have pain, they get depressed. Depression gets worse, lowers the threshold for pain, more pain. So pain is a huge problem in these patients. So stepwise management of pain and cirrhosis. Like you said, treat cause whenever possible. Local pain, somatic pain. So find out, is this somatic pain or is it neuropathic pain? Somatic pain, local measures first. Massage, heating pad, those will help. Then paracetamol, small dose of paracetamol. And if that still doesn't work, then hydromorphone. But hydromorphone you cannot give if they have renal disease, okay? Neuropathic pain. Neuropathic pain, use gabapentin. You have gabapentin here? Yeah. Pregabalin? Yeah, and tricyclics. So we start with tricyclics. Cheapest and easiest for neuropathic pain in these patients. No non-steroidals, tramadol or oxycodone. Tramadol and oxycodone, high risk of addiction in these patients. And no non-steroidals for reasons that we spoke about before. And then the problem with oxycodone is hepatic encephalopathy because of the constipation that they have. So pain is a problem. Start simple, treat whenever the cause whenever possible. So summary for pain. Local treatment before systemic treatment. No non-steroidals. Opiates only if absolutely needed. And when you use opiates, let's say they've had surgery, they've had a fracture, they need pain and they need opiates. Usual rule, half the dose and interval twice as long. So whatever dose you're using, start with half. If you're giving typically 6 hours, and these patients give every 12 hours. Okay? So take-home messages for improving quality of life. Huge impact. You can treat with beta blockers, you can treat with what you want, but if they're not going to be happy unless they feel better. Patients should feel better, and there's a huge impact on quality of life. If they feel poorly, they will have worse outcomes. Most important is reassure patient that you will try and help them. You can tell them it's difficult, but say you will try and help them. I think that's important for patients to know that at least you are on their side. We have an honest discussion saying, okay, this I think will work, this may not work, we'll try our best to help you. So reverse what you can. If you cannot reverse it, relieve what you cannot reverse. And most of all, always be there for your patients to help the patient cope with symptoms. Okay? Thank you. Okay, so questions on symptom relief. You have a question?
In patient with decompensated cirrhosis with DVT, which anticoagulant to give? Or acute coronary syndrome, which antiplatelet to give in decompensated cirrhosis?
So your question is acute coronary syndrome?
DVT. My first question was in DVT.
Oh, deep vein thrombosis. Good, very good question. So we always think of cirrhosis as a bleeding disorder, but cirrhosis is mainly a clotting disorder. Spontaneous bleeding is not common. So these patients have a higher risk of bleeding. They have a higher risk of deep vein thrombosis in hospital. They've got a higher risk of pulmonary embolism, and they've got a higher risk of mesenteric venous thrombosis. So in hospital, deep vein thrombosis prophylaxis is necessary in these patients, and we use low molecular weight heparin in them.
And in acute coronary syndrome, which antiplatelet?
They will die from the acute coronary syndrome. Please anticoagulate these patients. You have to anticoagulate them. And use whatever anticoagulation that you want. Remember the general rule. If your choice is between anticoagulation, because of they're getting thrombosis, versus bleeding, which is resulting from anticoagulation, always favor anticoagulation. Because thrombosis is associated with mortality. They will die from their cardiac disease if you don't anticoagulate them, or they will get a stroke, which is major morbidity. Bleeding, we can fix. So yes, please anticoagulate them.
Thank you, sir. Again, excellent demonstration and discussions. We go to the next session. Thank you, my co-chairs, as well as the panels. We are in time. Akash, we have given you the mic back. It's on time. Thank you, sir. Thank you, sir.
And GK, thank you for no googlies.
Thank you, everybody. And yes, as Kingshuk sir said, we are dot on time. With this, we'll move on to the next session. The next session is on incidentally detected hepatitis B in a pregnant woman, and I would like to call upon the chairpersons for the session, Dr. Sudipta Ghosh, Senior Consultant Gastroenterology at AMRI Hospitals, and Dr. J.R. Mahapatra, Senior Consultant Gastroenterology at PLS Hospitals. And to take away through the session is someone whom for here or in India or globally we need no introduction. He has been a pioneer and a stalwart in the work of hepatology, in various aspects of hepatology. And I would like to call upon stage Professor Abhijit Chaudhary sir to take us through the next session.
May I call upon the panelists for this session, Dr. Shouvik Mitra from ILDS Kolkata, Dr. Prashanjit Haldar from IPGMR Kolkata, Dr. Debarshi Bose, Associate Professor, Department of Hepatology, Dr. A.K. Pal, Senior Consultant, Gastroenterologist, Ruby General Hospital, and Dr. Moinuddin Ahmed, Associate Professor, Department of Hepatology, IPGMR Kolkata. Over to Abhijit, please.
A very good evening to all of you. We had so far been discussing a lot on issues that are, with advanced liver disorders and particularly non-alcoholic fatty liver disease. And what I'm going to discuss, and we are going to discuss with you in the next half an hour or so, is an issue which has got multiple connotations in terms of management and all. So let me go straight to the case. The case in question is a 22 years old female. And I think most of you would be feeling that this is something which I have just seen a couple of days ago. She is primigravida. She has been found to be HBsAg positive on an antenatal check, and her mother is being treated for HBV-HCC. That is that is what came out on history. So she has got a family history of hepatitis B virus related liver disease, and now she came to us, and this is a real life case. Let me tell you that she came to us telling that she has been advised by a obstetrician and a physician combined together, I'm just sharing with all of you, to terminate the pregnancy. She was in first trimester and she had been advised that. So she wanted to have an opinion for me of, first question was this. So let me first put the questions that, all questions that she had and other questions that we as physicians are going to face. What should I do to my pregnancy, with my pregnancy? Because she had been told by somebody that she needs a medical termination of pregnancy. Can I deliver an uninfected child? If I cannot, then tell me how safely I can abort. How should I proceed? If I can, then tell me how should I proceed on that. Question 2, because the most important for any expecting mother, the first question is well-being of the child in the womb. Next question is, what should I do? And could you help me regarding my infection and if I have got a liver disease? People tell that getting HBV is bad. So, do I need any treatment? So that was the second question, lower down. The first question was higher up. Third question was, then if you tell me that I need to have a delivery, then should I have a normal vaginal delivery or a cesarean section? She was quite educated, and these were all the questions. And what would happen to breastfeeding? And finally, as we go on into the discussion, we will decide, we will discuss as what's happening out in real life out here. So while we go into discussion and I put the questions one by one to the panelists, I would request your opinion on how should I answer the first question about indication or medical termination of pregnancy. Can you, some of you raise your hands on whether I should advise a medical termination of pregnancy for this lady or not?
No.
So the first opinion of this house and the first clear opinion that we should have is maternal HBV infection is not an indication for medical termination of pregnancy. And for why I am telling this is keeping on happening. And I would be most happy if after today's meeting we can recirculate this into our hundreds of patients and all those circles. That would do tremendous social justice apart from being medical justice. Let me tell you that ultimately our opinion out here, there is a lady who is really troubled, not because of her only, because of what's going to happen to the fetus. So our opinion, whatever opinion all of us give, has to be scientific, most importantly, because you cannot be, quasi-scientific or less than scientific. It has to be rational, but let me tell you, it has to be social also. Keeping Indian family structure and other ambient social structures in mind, and also emotional aspects. So you have to be very balanced and gradually open up all your stories, because we are going to deal with the lady for the next couple of months and the obstetrician is going to tell you. So my first question is, how are we going to evaluate the mother? May I ask Dr. Shouvik Mitra as to what is there in your mind as what all should we do in terms of evaluating this mother in planning a holistic management?
So we have to assess a liver function test with special.
Loud. I'm not hearing.
We have to assess a liver function test, particularly with special emphasis to albumin, ALT, AST. Then we have to assess whether the virus is applicative or not. So hepatitis B E antigen, whether it is positive or negative. Then to assess the replication, hepatitis B virus DNA, and it must be a quantitative DNA. And then we also need to assess non-invasively whether this mother is cirrhotic or not, non-invasive measurements.
So, as Dr. Mitra had suggested, I think what we need to do is we need to assess whether the lady is E antigen positive, what is the replication status, what is the liver function status or not. So if I say, if I mention the tests and their values in evaluation of any HBsAg infected person, we test what does HBsAg positivity indicate. I think all of us know this, but this is the basic primer which you keep on enunciating every day. So presence of HBsAg indicates only presence of infection and nothing more than that. So we need to keep in mind that most of the people who are HBsAg positive don't have significant advanced liver disease with them. But we need to also keep in mind that they might still be having significant liver disease despite being asymptomatic. The person might be walking, hale and hearty, apparently. But unless you investigate, you cannot really be sure what is the status of liver disease. So you need to do some virological tests. So we know of the E antigen, which is a very interesting and important serological marker which indicates replicative infection. But the most important marker for replication that we have got in hand is, as Dr. Mitra has mentioned, is quantitative HBV DNA. We will come to value of that. That is the replication cohort, best marker for guiding therapy as of now. But I wish to emphasize that we need to do a E antigen, and why I am emphasizing this is, unfortunately, the national HBV guidelines don't tell us to do E antigen in the patients. That's not the right thing to do. No HBsAg positive patient should be categorized before therapy without doing any antigen. Please categorize your patient based on E antigen positive or E antigen negative. That's something which is missing in the national HBV control program, but that should not be done in your clinical practice. So do E antigen, do HBV DNA. If the person is E antigen negative and anti-HBV positive, the person is generally non-replicative, but not always. There is a variety of people with anti-HBV positivity who have got elevated ALT, high HBV DNA, so it's called E negative hepatitis. So anti-HBV generally indicates, quiescent phase of infection. And please do ALT, SGPT. I want to mention here that not having an elevated ALT is really not a good scenario. Rather, if you have got an elevated ALT, you should be happy because you have got a window of opportunity to treat this individual. So don't get upset if your person have got a SGPT which is say 80, and rather I am upset if my patient have got an SGPT of 20, because I cannot treat the individual based on, because ALT indicates the immune response that is happening to the virus, and that's all the determinant in hepatitis B virus infection. So these are all the parameters that you should do. And now we did all these parameters in this lady, so HBV DNA, E antigen, anti-HBE. We did liver function test, and we also did a platelet count. Why platelet count? Platelet count, simply speaking, from a generalist point of view, is a very good marker in hand that can tell you about the presence of portal hypertension. Forget all those measures. It's single most useful bedside test to tell you whether chronic liver disease and portal hypertension is present or not. Many patients who come to you with low platelet count will finally turn out, and we have seen many people who have undergone bone marrow biopsy before being discovered to have chronic liver disease. So include evaluation of liver function and liver disease status in every patient with low platelet count, and do a hepatobiliary ultrasound. So these are the possibilities that can happen. You can have E negative, anti-E positive, undetectable quantifiable HBV DNA, and a normal ALT. These are the largest subset of people. These are the so-called inactive HBV infection, which we had been calling as HBV carrier. Remember that an inactive is not always inactive. So even if you have got an inactive HBV infection, you should tell the patient that you should keep on measuring your DNA and ALT every 6 to 12 months. So they are not off the hook. So your objective is to keep that person on follow-up for prolonged. On the other hand, on the other extreme, the person may be E or anti-E positive, HBV DNA is say 3 into 10 to the power 3 copies, ALT is 24, and ultrasound shows irregular margins and low platelets. What does it indicate? It indicates presence of advanced chronic liver disease. So that's the other extreme. In between, this lady had a, please note each of these steps, because you know HBS, AG positivity does not mean much unless you categorize the patient well in planning for management. This lady was E antigen positive. HBV DNA was 10,000 international unit per liter. ALT was 65. Platelet was 200,000. So, now, how should we plan the management of this patient? Maybe Dr. Moin tell us what should be our plan of approach to this lady.
So here the major issue is perinatal transmissions. So you know there are two important factors that predict perinatal transmission. One is E antigen positive.
So could you tell us fast, this patient, do you plan to treat this lady in pregnancy, and if need be, how?
See, there is no emerging indications for treatment. If cirrhotic, you start treatment, no problem. But in non-cirrhotic, you can wait and observe. You may start therapy later on. But there are many people who want to start treatment because you have a very effective drug, and that drug is tenofovir, and that drug is also safe. So if you start treatment, you need to continue therapy almost lifelong because your endpoint is surface antigen loss, which does not happen. So there are a group of people who will offer only vaccine. There is the active and passive immunization of the newborn baby. They will defer treatment. And there are some people who may prefer antiviral.
Okay. So, Dr. Moin's suggestion is we can wait during this pregnancy because the lady have got a, ALT which is elevated. But now say one of the important question is people are very anxious. So in that case, if the person wants to get treated, then you probably could not deny the benefit of treatment to this lady. Then the question comes, how to treat these people? So you have got option of telling the patient, counseling the person, the pregnant lady, that your liver disease is not as great as, warranting treatment right now. But remember, drugs are very safe in 2024. So that you can use them during pregnancy. So what are the drugs that are in your hand? So first of all, we need to know who needs antivirals clear cut. This person was not, so DNA of 10,000 international unit. I wish you note this. I'll come to right now to detail why I'm telling this. ALT was 65. So upper limit is 40. So it's 1.5 times elevated. Platelet is good. So the person does not possibly have got chronic liver disease. So have got chronic E positive hepatitis with a variety of borderline elevated ALT and a borderline HBV DNA. So now the question is who always needs treatment? The person have got a ALT elevated which is more than 2 times, say 60 or 80. If it is more than 80, you close your eyes. E antigen positive or anti-E positive. Now the question is, your DNA titer is different for cutoff, is different in E positive and E negative. In anti-E positive, if it is more than 2,000 international units, you treat the individual. These are the guidelines. I mean, more or less, most of the guidelines. In E positive, you have got 20,000. So it's higher amount of DNA. Evidence of cirrhosis, if there, any amount of quantifiable DNA would be make it candidate of therapy. But our patient was not something like this. This person fell into the gray zone. There are many varieties of gray zones. So now the question is, how should we decide the decision to treat the individual in the gray zone? I would like to emphasize that this lady had a history that her mother was being treated for HBV-HCC, telling that she has got a family history of hepatitis B virus infection and a family history of HCC development in the family. And she would be very anxious to be treated and would not like to waste even a single day of her treatment. So in that case, I think Moin's approach may not be the one that is acceptable to the patient. So which nucleotide analog? Remember earlier we had a very good drug in hand which is obsolete now, It's called telbivudin. That was fairly safe. Many data on safety of antiviral has come from telbivudin. Right now, your drug of choice in 2024, as Moin has mentioned, is tenofovir, tenofovir, tenofovir. You have got TAF in hand. TAF has also been demonstrated to be safe, but it's not part of the guidelines. Remember that. We, in real life, in clinical practice, we can use TAF, but close your eyes and use tenofovir and discuss the benefit versus risk with the patient and the spouse. Because the patient is pregnant. So tell that you can wait, but since you are trying and you are in the gray zone, I would like to treat you, and treatment has to continue. So that should be your approach. Now the question is, the third question, and what's the most important, how can you protect my child from being infected? So that is what the lady would like to most importantly know, that, we all decided that we are not going to abort the fetus. So we are going to protect the child in womb. So how can we do that? So maybe, maybe Apurvoda, could you have some opinion on this?
Yes. A child must be protected from getting infection. The baby, as soon as he or she gets born, he or she should be immunized with, not passively, with immunoglobulin at the dose of 0.4 microgram per kg body weight, and then he has to immediately should be actively immunized with vaccine, that is 10 microgram stat dose. I think this is the thing we can do. Then now your opinion.
So Professor Pal has just mentioned that at birth there are ways of preventing maternal to child transmission, which is called MTCT, fairly established. Dr. Moin, would you like to add to what Professor Pal has just suggested? Yeah.
You must offer active and passive immunization newborn, and should be done as early as possible after resuscitation, preferably within 3 to 4 hours. So if you give vaccine within 3 to 4 hours, the chance of transmission will be very low. But if your viral load is high, so if viral load is more than 2 lakhs international per ml, then you need to offer antiviral, particularly 28 to 32 week of gestation, and you continue for at least 3 months after delivery. Otherwise, active and passive immunization is very safe and very effective.
Yeah, Sudipto, Dr. Ghosh, you have got an opinion to tell us?
No, I think I was going to say what Moim has said, that we have to give both at the same time, active and passive immunization, rather than only depending on active one.
Sir, I have one point regarding use of immunoglobulin. Immunoglobulin is a very costly therapy. Now in this patient is E antigen positive. It is safe that we can prescribe immunoglobulin. But in patients who are E antigen negative, mother who is E antigen negative, giving passive immunization do not provide any additional benefit if you provide only active immunization with HPV vaccine and complete all the 4 doses of HPV vaccine. So if E antigen negative, particularly in country of India, we can also safely omit passive immunization with immunoglobulin also. That's the point I would like to make.
Okay, so everybody's opinion is most important phase is immediately after birth. We should not lose any hour to the child after birth. But what I would like to mention is every day counts during pregnancy. So say, for example, the lady has presented to you on the first trimester. You should taste HPV DNA during the second trimester and almost always at 24 weeks. So never forget to taste HPV DNA at 24 weeks. Why? Because it has been proved that the titer of HPV DNA, if it is more than 10 to the power 7 or 10 to the power 8, is the most important predictor for MTCT, maternal to child transmission. So always taste as soon as possible and always at 24 weeks the mother's HPV DNA quantification. And you can also taste E antigen. Say, for example, you don't have ability or facilities for tasting HPV DNA. E antigen is good enough, almost 88% correlation with HPV DNA. So if this mother was HPV antigen positive, so for all practical purposes, they say that if it is more than 10 to the power 6, you treat the lady, start treating the lady with tenofovir to prevent perinatal antiviral therapy starting at 20 to 32 weeks. So, we should not lose a single day. If the HBV DNA is more than 10 to the power 6 or 10 to the power 7, we should start antiviral starting at 24 weeks of therapy. And continue that to at least after birth of the child or to 12 weeks. I'll come to that. But before that, I would like to mention that prevention, mainstay, as all have mentioned, is HBIG plus vaccine. Both administered at the fastest possible time after birth. We should not delay it more than 24 weeks. And let me emphasize that one of the causes of failure of HBV prevention to the child is delay in giving vaccine or HBIG, because it's often not available. Many areas, particularly in India, are very resource constrained, and there are other barriers. I'll come to that. So efficacy is 95%, even more than that. And reasons for failure: delay, failure to complete vaccine series. Remember that this should be, this birth dose vaccination, BD, remember BD should be monovalent. But this should be followed in 6 weeks by the pentavalent vaccination that is being given in the national immunization schedule. So then it becomes a series of inoculations that we should give. And we should complete at least 3 vaccinations to the child, and the child is almost protected. And if the mother is E antigen positive and have got a high HBV DNA. Now, tenofovir, as I mentioned, has been proven to be of value in preventing maternal to child transmission. So as I was mentioning, so the frequency of transmission is almost 90%. If the mother have got a HBV DNA which is high and E antigen positive, this is the worst case scenario. We are not going to allow that happen even today. If the mother have got a low HBV DNA, the chances of transmission are very low, less than 10%. Now, only HBIG, chances of transmission are 30%. With HBIG plus vaccine, you further reduce it. And now in 2024, in a lady with more than 10 to the power 6, you should use antiviral in the 3rd trimester or 24 weeks. Standard management with HBIG vaccine plus tenofovir, you have got almost zero. I told you that it's less than 1% chances of transmission. So we should not use any wastage of day for prevention of transmission. Now the question is, does a CS help? Should the lady have a CS? And the other question is, the lady asks, should I breastfeed my baby? So maybe I would ask Dr. Prosenjit, what is your opinion on CS?
In case of cesarean section, so preferred is normal vaginal delivery until unless is a maternal indication for cesarean section. There is no added advantage of cesarean section so far. The data says.
So, yeah. So there are studies which have shown that there is no difference between normal vaginal delivery and all those other modalities of assisted delivery in people who have got, who are HBs antigen positive. Some studies from China, from very high viral load and hyperendemic regions, have shown that if you cannot give HBIG and vaccine, then cesarean section may help. But I wish to emphasize that hepatitis B, particularly if you have given tenofovir, which is very well available almost everywhere in the country, particularly with the national hepatitis B prevention program in force, we should not use any opportunity, and this should not be a justification for doing a cesarean section. Now, Shobik, your opinion about breastfeeding?
Definite yes. Definite yes.
Okay. So it's a big answer, yes. Nobody has got the right to be denied of the benefits of breastfeeding. There are ample studies, thousands of studies, which have shown that breastfeeding is one of the best gifts that a newborn can get, and we should not deny. And the other thing is that there are the safety of breastfeeding in a large meta-analysis and systemic review has also been shown that breastfeeding after proper immunoprophylaxis did not contribute to MTCT transmission of HBV, and neither does it interfere with the immune response to the child which we are going to give. So HBV immune response. So we should allow and encourage, not allow, encourage breastfeeding and always decry formula fed, because it has been shown that formula fed children don't have reduced chances of breastfeeding. So I'll come as we are, these are the usual questions, and so we have decided that we are not going to do a medical termination. We are going to carry the pregnancy forward. We are going to treat the mother if the mother is anxious, and particularly if the mother had a family history of HBV-HCC. So and we were going to prevent the child. So if we summarize, so what is the management trajectory in a patient with pregnancy and HBV infection? It should start as soon as the lady had been detected to have HBV infection. So it should start, we should have a good HBsAg screening program. I think Dr. Moin, who is in charge of the state's HBV prevention program, will tell us soon what they are doing in the state, and that would be good for everybody, who are the physicians and everybody. So HBsAg screening should be part of our antenatal checks. That should be done at the earliest possible time. Then we might do HBV DNA in HBsAg positive individual, and then always at 28 weeks. Remember, if the mother, as I told you, if the mother have got a HBV DNA which is high, say 10 to the power 6 and more, we should start tenofovir and continue that to around 12 weeks. And most important is 24 hours, the period of 24 hours at birth, when we should give monovalent vaccine, maintaining the cold chain, should not delay the bulk dose vaccine, and then that should be given at 2 months, 4 months, and 6 months. Check the child of a E antigen positive, high DNA mother at 7 months with HBsAg. So before 7 months, you are not sure, so I'm not going to detail why 7 months, because that's the usual time when the maternal things pass off and all. So at least 7 to 12 months, you test the child and the child is off the hook. So that should be your until the child is not HBsAg positive, and that then you tell. So I would request Moin now to tell us what's happening in the state on hepatitis B prevention and how we are dealing with the mothers.
So WHO has given very ambitious goal, eliminate hepatitis B and C by 2030, which is not practical and not feasible also. So any government of India launched National Hepatitis Control Program 2018, and state West Bengal actively participated in this program. So during last 2 years, during COVID era, we established 33 treatment center for hepatitis B and C. These treatment center offer investigations like screening for Hep B and Hep C by rapid diagnostic kit, and also provide drugs both for Hep B and Hep C. But they don't provide molecular tests like a DNA estimation or RNA estimation. For that, we ferry blood sample from the treatment center to model treatment centers. And we have 2 model treatment center, 1 Apex treatment center. And all these model treatment center, Apex treatment center, they are equipped with fully automated PCR machines. So we estimate viral load in model treatment center and Apex treatment center and distribute that report. So if you look at our data, 2019-2020, we do not have any data regarding ANC checkup. Subsequently, we upscale our screening program, and at that time it was restricted to medical college only, and you can see that antenatal screening for Hep B was only 3%. Subsequently, we involved district hospital also, so that further it increases to 12%, 83%, and now the rapid diagnostic kits are available even in sub-center and health center. So if you look at the total number of deliveries and screening for viral hepatitis, it is almost 100%. And at present, immunoglobulin is available in everywhere. It is available in primary health center, district hospital, sub-center, everywhere. And if you look at the immunization coverage rate, it is almost 100%. So this is our achievement. So we have scaled up the screening. We have started adequate immunization, adequate vaccine coverage. We have also started triple elimination programs. This is the first time we introduced in our state. triple elimination means you eradicate syphilis, HIV, and Hep B. So use a rapid diagnostic kit and make a diagnosis of viral hepatitis B, HIV, and syphilis, and you treat or prevent. So far, this program is this is only restricted to few districts. So as a pilot project, we have included 4 districts. So this is district to Rampurhat, Diamond Harbour, 24 Pargana, and Coach Behar. So we believe that in next few years we will cover the entire state, and it will help to eradicate 3 important diseases which are maternal to child transmission, that is a syphilis, HIV, and Hep B. Thank you.
Okay. So we stop there. I think if there are questions, we can take that up.
Professor Chaudhary, may I ask you the question, sir?
Sure.
Hello.
This side.
Oh.
It's a completely different group of population. When do you advise your cirrhotic patient not to get pregnant?
Not to take?
Not to get pregnant. Advice against pregnancy. Which stage of cirrhosis?
Okay. It's, I think this is a very sensitive question because, you know, becoming pregnant is probably one of the most emotional and natural thing. Only in advanced decompensated cirrhotics, you can say that we really don't advise you to become pregnant in the near future. But that should also be very emotionally balanced and all. But otherwise, our approach should be positive and encouraging.
Can I ask a question? E antigen negative, will you answer the question? E antigen negative, will you avoid IgG? I mean, immunoglobulin therapy.
I didn't follow. E antigen negative?
Immediately after birth, immunoglobulin not to be given.
The issue is not to be given is very difficult to say. I think one should keep that everybody should get HBIG because this is a package. HBIG and vaccine at birth. Otherwise, the entire program would fail. So let's not discuss that, specific window which is very small.
Thank you, Dr. Avijit, for excellent presentation. I think we will not take any more questions. We will wrap up this session. I'll thank my co-chair as well as the daily faculties.
Thank you.
Thank you.
Thank you.
So with that, we come to the last session of the day, and we discuss in the last session the 3 commonest things that you associate with cirrhosis, that is ascites, variceal bleed, and hepatic encephalopathy. For the last session, I would like to call upon stage the chairpersons, Dr. Professor S.P. Mishra, sir, who is the professor and head of Emilian Medical College, Allahabad, and Dr. Kingshuk Dhar, consultant gastroenterologist at GD Hospitals, Kolkata. I request the chairpersons to call upon the panelist, and I also request sir to come and take us through decompensated cirrhosis.
So we are here for the last session now. May I call the panelists, Dr. Joydeep Ray, consultant gastroenterologist, Sri Aurobindo Seva Kendra and Kasturi Nursing Home, Kolkata. Dr. Gautam Das, senior consultant, Department of Gastroenterology, MRI. Dr. Pradipto Sethi, Head of Department, Gastroenterology, Medica Super Specialty Hospital, and Dr. Sujoy Roy, Associate Professor, Department of Gastroenterology, RG Kar Medical College, and Dr. Sudipto Ghosh, Consultant Gastroenterologist, AMRI. May I call on stage Professor Patrick Kamath. This is an important session on decompensated cirrhosis and upper GI bleed, ascites, and hepatic encephalopathy.
Oh, thank you, SP. Can you hear me at the back? Oh, good. Thank you. Okay, so end of the day, sleepy, so lots of questions. Okay, I'm going to start off with questions and I'm going to give you the answer only at the very end. So, patient has ascites, uncontrolled, spironolactone 100, furosemide 40. These are your choices. Increase spironolactone to 200, anyone? Furosemide to 80. Increase spironol to 200 and furosemide to 80, both combination. Few. No diuretic change. Weekly paracentesis. Discuss compliance with low salt. Some more. Okay. Next question. Large volume paracentesis, safety precautions. INR less than 1.5, platelets 100, limit to 5 liters, limit to 10 liters, IV albumin, ascites, okay. Panel, what do you think? Before a paracentesis, what do you want done? What is the minimum hematological workup you want before a paracentesis? You want platelets, prothrombin time?
Prothrombin time is not so much important before paracentesis.
Yeah, it's...
You can speak normally.
Do you want platelets or prothrombin time? Yes or no? Good. Okay. Hepatorenal syndrome. True or false? Hepatorenal is the most common cause of acute kidney injury and cirrhosis. Classified as type 1 and 2. Urine sodium greater than 30. Marked arterial or vasoconstriction in extrarenal circulation. Albumin and midodrine very effective. What do you think? All just true or false? Just true or false? Most common cause of AKI and cirrhosis, true or false?
False.
Classified as type 1 and 2?
Yes, true. I think new classification is different.
Urine sodium greater than 30. Arterial or vasoconstriction in extrarenal circulation?
True.
False. Albumin and midodrine very effective? Okay. Now this is new. Lactulose dose. So patient has hepatic encephalopathy. Okay. On the right you can see the Bristol scale for the stool. I'm giving you each scenario, you tell me. So patient has 4 type 1. So that is type 1 there. 4 type 1 Bristol stools with encephalopathy. Will you increase dose of lactulose? Show of hands. 3. 1 type 7, just 1 type 7 Bristol. No encephalopathy. Increase? No. 2 type 5 stools with encephalopathy. Won't increase. Or will you increase? Patient still has encephalopathy. Increase or no increase? So, 1 type 6 Bristol but no encephalopathy. No stool but no encephalopathy. Do you want to take yes or no? Only yes or no answers. Because with the last session, Dr. S.P. Mishra is keeping time, so he'll get me in trouble if I go beyond 9.
Increase the dose.
Which one?
E.
Type 1 A? Yes or no? That's all.
Yes, increase. Yes, increase. Increase.
2, B?
No, no.
C?
Yes. 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 Yes.
So A and C you say is correct. Okay. The following are side effects of lactulose. Hyperkalemia?
No.
Hypokalemia? Hypernatremia? Hyponatremia? Abdominal bloating? Okay. Just yes or no. True or false? Hyperkalemia, yes or no?
No.
Hypokalemia?
Yes.
Hypernatremia?
Yes.
Hyponatremia?
Yes.
Abdominal bloating? Good. Nice to have a panel where everyone agrees, because sometimes they say yes and no. Two say yes and two say no, so I never know what the answer is. So good. Okay. So, let's go to basics, complications. We'll go over the physiology of portal hypertension. We'll go briefly over bleeding. We'll go a little more over ascites, because this is what you as physicians are going to be treating. Little more about hepatic encephalopathy. Also bleeding we won't go over much. So here is the first thing which happens. So there is scarring in the liver. There's increased resistance. That elevates portal pressure. Okay, first thing. Second, because of a lot of vasoactive factors, there is increased portal flow. So that combination elevates portal pressure. When portal pressure is increased, new collaterals form. That increases variceal wall tension, and patients can get variceal bleeding. So that is first complication, bleeding. With elevation of the portal pressure and renal retention of sodium, you get ascites, sorry. And then with collaterals and hepatic dysfunction, you get hepatic encephalopathy. So this is the basis for all complications of cirrhosis. Let's go over bleeding first. No varices to small varices to large varices. Rate of change is about 7 to 8% per year. So generally, if you have no varices 1 year, it will be 10% the next year. However, if they are drinking, they're decompensated, it's going to be higher. But generally, assume it's about 10%. Okay. Now, why do varices bleed? Anyone? Because they are large? Most important, only one answer is correct here. Wall tension increases, high portal pressure, because the varix wall is thin. Do you want to answer?
C.
C.
High portal pressure.
So, if portal pressure was high and the wall was thick, would you bleed? Gastric varices, pressure is high, but they don't bleed as much as esophageal varices, so it's the same pressure. So does pressure make the difference? So remember, a varix is like a balloon. You know, all of you. You keep blowing it, pressure is increasing, but the wall is becoming thin. And the difference in pressure in the balloon and outside is going to determine whether the balloon will burst. Okay? So that is called wall tension. Wall tension is a product of transmural pressure times radius divided by wall thickness. In the esophagus, varices are not supported, so thin wall. Intrathoracic pressure is negative, so transmural pressure is increased. That's why they will bleed at the lower end of the esophagus. When you go up, they are supported and there is a perforating vessel. In the stomach, intra-abdominal pressure, so transmural pressure gradient is lower, wall is thicker, that's why gastric varices bleed less than esophageal varices. So, wall tension is increased, so which is a combination of many factors. So what are your options for bleeding? Your pharmacological treatment, you've got endoscopic variceal ligation, and you've got shunts. Like I said, we don't have time to discuss each in detail, but let's look at the mechanism of action. So we went over this before. Increased resistance to flow, increased portal pressure, there's vasodilatation, which increases blood flow, which causes portal hypertension. So use something as a vasoconstrictor. So decrease splanchnic blood flow, that will increase resistance, that decreases portal blood flow, and that decreases portal pressure and less risk of bleeding. Okay, so beta blockers decrease flow. Varicose band ligation does not do anything to pressure, works directly on varices. If you look at tips and surgical shunts, they decrease resistance to flow, which decreases portal pressure, which decreases the risk of varicose hemorrhage. So these are the mechanisms of action of agents or treatments to treat varicose bleeding. Here are the practical issues, and especially for the physicians in this room. Measure resting heart rate and blood pressure. I know it's expensive. If patient can manage something at home, that's good. Carvedilol is preferred. Use a long-acting agents. There are many drugs you can use, but the more times a day the patient has to take it, the more likely they will miss a dose, and especially if they're working. So try and move towards one-day treatment for everything. So use a long-acting preparation, use carvedilol. We know the risk of bleeding is most at night and early morning, so administer once daily in the evening. Target resting heart rate decrease by about 25% or to 55 to 60 beats per minute. So this is the simple part of heart rate. So patient has varices, put them on a non-selective beta blocker, you're going to decrease long-term risks. If they bleed, that is for the front row, and we won't go over that. This is mainly for the physicians in this room. Ascites is a bigger problem in here, okay? So if a patient comes to you with ascites, most common cause worldwide is cirrhosis. You have cardiac failure, you have cirrhosis and cardiac failure, malignant ascites, and other causes. But these percentages will change. So it depends which hospital you're working in. If you're working in a cancer hospital, then probably 50% is going to be malignancy. If you're working in a cardiac hospital, you'll get more cardiac disease. If you're in an infectious disease or a general hospital, you'll get more tuberculosis. But in general, cirrhosis is going to account for most patients with ascites. So first, when a patient has ascites, think of cirrhosis. Then if you rule out cirrhosis, think of the other causes, and I'll go over how you find that out. So why do you get ascites? We'll come back to this figure, which I'll keep showing you. Increased resistance, increased sinusoidal pressure. This vasodilatation. So vasodilatation means there's a drop in pressure. So same amount of blood flowing through a wider space, that is called a decrease in the effective arterial blood volume. The volume is there, but the body thinks there's less volume. So the kidney will retain salt and water to try and increase the blood volume. So that activates systems which will retain sodium and water, and you get ascites, okay? So this is why you get ascites, sodium and water retention. So I told you, once you have ascites, you need to find out, is this cirrhosis or is it not cirrhosis? Because that's 80%. So the ascites can either come out of the hepatic sinusoids or it can come from the peritoneum. How do you differentiate that? Use the gradient. Serum acetic albumin gradient greater than 1 tells you it's coming out from the sinusoids. It's going to be chronic with cirrhosis, and the total protein will be less than 2.5. More acute, the sinusoids are still leaky, so protein can leak out, so the total protein is greater than 2.5. So this is with cardiac disease. So is this clear to the physicians at the back? Measure the albumin in acidic fluid, measure albumin in the blood, the difference is the gradient. If it is greater than 1.1, it's coming out of the liver. If it's less than 1.1, it is coming out of the peritoneum. Okay? So if it's coming out of the peritoneum, the total protein is high, it is inflammatory, and so you think of malignancy and tuberculosis. So your first step when a patient has ascites is finding out where it comes from. Most often it's going to be liver, but make sure you have ruled out other causes. So this means you must check albumin in the blood and in the acidic fluid. So consider a paracentesis in anyone who has ascites. So the first time, if you know they've got cirrhosis and they come to hospital, check ascites again because they may be infected. If they have symptoms, abdominal pain, fever, acidic tap. Kidney function worsening, they've got encephalopathy, you cannot explain, acidic tap again. So generally, anytime there's a deterioration of the liver condition, think of doing a paracentesis. Okay? There's really no contraindication to a diagnostic paracentesis. You heard from the panel, don't worry about the platelets and prothrombin time. It's a bit of a problem in patients who are infected. They bleed very easily. And that's really not related to the prothrombin time or the INR. Infection makes you bleed. So infected patients, especially inpatients, be a little careful of the paracentesis. Really, if you're training people, they should do outpatient paracentesis. Inpatient, only more experienced people should do. Okay, now we're coming back. So patient has ascites. When do they become refractory? So if the liver disease gets worse, decrease in arteriolar resistance, further decrease in arterial blood volume. In general, the worse the liver disease, more the vasodilatation. That decreases the effective arterial blood volume, more activation of neurohumeral systems, more sodium and water retained, you get refractory ascites. Clear? Even more vasoconstriction, you get hepatorenal syndrome. So in case you miss this, to summarize, there is vasodilatation and cirrhosis, which is sensed by the kidney as a decrease in the effective arterial blood volume. That activates neurohumeral systems. Sodium is retained, so you get ascites. There's renal vasoconstriction, so you get hepatorenal syndrome. There is water retention because of antidiuretic hormone, and you get hyponatremia. So this is the basis for ascites, and we'll talk about treatments here. So you see the patient, initial workup, just the protein, I told you. Serum acetic albumin gradient, you'll find out if it's got cirrhotic ascites. You'll also do cell counts, if necessary, bacterial cultures. That's all the tests you need to do in patients, 80% of patients. If the gradient is low, then think of tuberculosis, malignancy, then you can do the other tests. But otherwise, routinely, you don't need to do all these tests. So how will you manage? We went over this before. So there's sodium and water retention, okay? Remember that. So when you give diuretics and you restrict sodium, they work on the sodium and water retention. So you have less sodium and water retained, and that decreases the ascites. So that's the first treatment. Or if that doesn't work, you can try large volume paracentesis and albumin. The albumin increases effective blood volume. The large volume paracentesis removes the ascites. That doesn't work, consider TIPS. TIPS increases effective arterial blood volume. In fact, the cardiac output increases post-TIPS. Sinusoidal pressure decreases, and that takes care of ascites too. Okay. So that's generally, now as physicians, you're going to manage uncomplicated ascites. So uncomplicated means responsive to diuretics, no infection, no renal dysfunction. So you can manage these patients. Sodium restriction, effective in about 10 to 20% of patients. Whom do you think that will work? Not much ascites, check the urine sodium. If the urine sodium is high, just restrict sodium in these patients. If you're going to start them on diuretics, spironolactone monotherapy is better than furosemide monotherapy. If they have tense ascites, use both. So that's going to be your basis. So what is the maximum dose of spironolactone you use?
400.
Everyone says 400 because, again, I said we are looking from the West. I have never used 400. It is impossible to reach 400 in a patient. Beyond 200, they're already getting problems. I've never used 300. And 400, impossible, but all the guidelines will say 400 maximum dose. 1/6 of furosemide. No patient survives that much. So typically, beyond 200, I'm having difficulty with spironolactone. Beyond 80 is furosemide. Maybe if they have a lot of low limb edema, I may go up on the furosemide, but spironolactone, if you go to 400, you're going to have a lot of problems with these patients. So again, don't follow guidelines. If in your practice you've never reached 400, has anyone ever used 400? But everyone will say 400 is maximum. So remember in practice what you use, try and follow that. Okay, sodium restriction. 2 grams, 5.2 dietary salt. South Indian diets higher in sodium than in North Indian diets. And why is that? More? Good. More pickles in South Indian diet. Don't restrict fluid. No need of restricting fluid. The only time you might restrict is if there's hyponatremia. So how much do you restrict fluid? What is the volume and why? If you're restricting fluid, restrict it only if there's hyponatremia. It's not that effective. The sodium will not go up, but it at least won't go down further. How much do you want to restrict it to? Good. Can you do it a little better? Good. People should follow that.
Urinary output plus around 6 to 7.
Plus or minus? Minus. Very good. So, don't give them 1000. It's very difficult to manage. Remember these poor patients, you're saying no salt, then no fluid. You know, it's very difficult for them to manage. So don't restrict water, let them have water. If they get hyponatremic, urine output minus 500. Okay? That 1000 milliliters, 800 milliliters which people give is very difficult. You know, they may manage for 1 day or 2 days, but then they're back to it and it's okay. So no need to restrict fluid. Restrict moderate restriction of sodium, restrict fluid, and remember you can go up on diuretics. The goal is get rid of more sodium than you take in. The problem is, you know, it's difficult to eat. You need protein. Protein has sodium. It's difficult, but that's the way you'll manage diet. Dose. Spironolactone, do you see a 400 here? No 400 in my slides. Furosemide 40 to 80. Now what's your goal? When you start treatment, what is your goal?
If patient is having edema, then along with ascites, 1 kg per day.
Good.
Max, or if without edema, half kg per day is it.
So at the end of the first week, how much do you want them to lose? You started them on treatment at the end of the first week. How much do you want them to lose?
2 kg maximum.
Okay, not more than that. And why? You said half a kilo per day, so it's 3.5, but you're happy with 2. I'm happy with 2, but why are you happy with 2? Because spironolactone takes a lot of time to work. Okay, so your first week is not the week to decide whether you've reached the maximum or not. Okay, so first week, 1 kilo is okay. Beyond the second week, you start with 2 kilos because spironolactone takes 5 days to act. So you're not going to get the benefit immediately. So if they're losing more than half a kilogram a day without edema, decrease the dose. If they have edema and they're losing more than 1 kilogram a day, decrease the dose. Side effects, renal dysfunction, hyponatremia, hyperkalemia, which makes encephalopathy worse, which makes gynecomastia, and gynecomastia too. So, how often do you measure urine sodium? No?
If ascites is unresponsive.
So, when you're following patients on treatment, you don't use sodium, urine sodium? Actually, I like urine sodium. It's a cheap test and really tells me a lot. If they're doing well, I agree. I don't need to measure sodium. If they're not doing well, I need to find out why. You want to say something?
Yeah, I think in the day-to-day practice, we do not check the sodium, but we check the sodium if we think that it is becoming too refractory ascites or the diuretic is not working. Then you revise your diagnosis whether it is adherence to the treatment or the patient is not taking the diuretic. Yeah. Then we check the sodium.
Yeah, I agree. So if they're doing well, no need to check. If they're not doing well, check. It's a cheap test. Okay. Here's how we won't go over the calculations, but they're taking 90 milliequivalents in. Remember we said that's a 2 gram sodium diet. You can measure the sodium or you can measure sodium potassium ratio. If sodium is more than potassium, they're losing good amount of sodium. If potassium is more than sodium, they're not losing a good amount of potassium. So that's an easy way of looking at it. So I hope you understand this. So the urine sodium is high. Patient is losing weight as you planned. So what do you want to do here? Urine sodium 90, patient losing weight. What do you want to do?
Decrease the dose of diuretic gradually.
Good. So this is diuretic sensitive. This is how you know. We also know patient is adhering to sodium restriction, so we won't change anything here. Urine sodium is less than 90. Patient is not losing weight. What does it mean?
We can increase the dose of diuretics.
Sure, increase the dose of diuretics, meaning at whatever dose you're giving, it's not working, so increase the dose of diuretics. Are you following me? You sure? At the back too, are you following? Good. Now urine sodium is more than 90. Patient is not losing weight. So it means your diuretics are working well. But not losing weight means the patient is taking in more sodium than the patient is getting rid of. So what do you want to do here? Restrict sodium. Go back on the diet. So that's how urine sodium helps you decide about treatment. Okay. More tips for management. Start 50 to 100 in most patients. Start small. Takes about 4 to 5 days for it to work. So you're not going to see a response right away, so don't get anxious quickly. Add furosemide to spironolactone if a patient has tense ascites, patient has lower limb edema. Spironolactone gets rid of about 3% of filtered sodium load. Furosemide gets rid of 30%. So furosemide is a much better diuretic than spironolactone. Generally, ratio 100 to 40. Monitor the weight, always good to do it at the same time after emptying the bladder. Like we said before, weight loss is 500 grams per day. If you have lower limb edema, it's 1 kilogram per day. And urine sodium excretion goal is more than 90 milliequivalents per day. What are the problems that you find in patients on diuretics? When do you give it Once a day, twice a day, 3 times a day, if you're increasing the dose.
Once a day. For furosemide, it can be given twice a day.
Twice a day.
The second dose by 4 weeks.
So remember, furosemide was called Lasix because it lasts 6 hours. So don't give anything in the evening. It'll work, but they won't sleep at night. So try and move everything, like I said, close in the day. The patients have got so many problems, at least let them sleep for a few hours. Try and make the dose just once a day. Try not to give everything in the evening, then they'll wake up at night. So use spironolactone with caution when the creatinine levels are going up, because these patients have a risk of hyperkalemia. Older patients. Now you're going to get a lot of patients with INASL. They have kidney disease. Again, be careful. Old patients, those with chronic kidney disease will get worsening renal function, so be careful in those. So again, when you go up on the dose, don't do the same dose for everyone. Look at the group of patients you're dealing with and then go up slowly. Ascites, you can mobilize easier. Pleural effusions, you cannot mobilize that easily. So don't be aggressive with treating pleural effusions. Also, we are treating for symptom relief. Acidic fluid, peritoneal space, there's a lot of volume, so you've got to get rid of a lot of fluid to feel better. Pleural effusion, if you do a thoracentesis of 500 milliliters, they feel great. So even 250 milliliters loss with pleural effusions is sufficient. Okay, so small volumes in these patients. So gynecomastia, do you have eplerenone here? You do? Yeah. So consider using that. It's just, I don't know cost, because when we look at costs, I was talking to Joseph today, everything in the US is 10 to 20 times what it is here. So eplerenone is very expensive in the US. Is it much more expensive here than spironolactone? Much more expensive? Not much, yeah. So I think you should consider using that, because eplerenone is a breakdown product of spironolactone. Okay, so 25 milligrams once orally, increase the dose 2 to 4 weeks to 50 milligrams once daily, and adjust the dose based on potassium levels. So, summary, use diuretics judiciously, and side effects are common, especially in older people. Large volume paracentesis, you can get rid of fluid quickly. Diuretics, you can use it more generally. Finally, hepatic encephalopathy. Neuropsychiatric problem, okay? We divide it into covert, which is hidden, versus overt, which you can actually see. Big problem, because it's increasing more hospitalizations related to hepatic encephalopathy. Stages, confusion, to drowsiness, to somnolence, to coma. These are the 4 stages. Okay. Case again. 55-year-old male, comes with encephalopathy, temperature 38.5, ascites, asterexis, white cell count 8.4. What will you advise now? Paracentesis? No one wants a paracentesis? Please? Anyone want a paracentesis? Good. CT head, abdomen, EGT, ammonia, not good. Okay? Remember what I said before, any worsening in the condition, do a paracentesis, because there's likely to have infection here. So, encephalopathy can be either precipitated by infection, GI bleeding, or medications, but infection and GI bleeding are going to be your 2 common causes. Some constipation, dehydration, tips, alcohol and drugs, don't forget they can worsen encephalopathy, and non-precipitated. Also remember this, change in gut flora. Proton pump inhibitors associated with increased risk of hepatic encephalopathy. Once a patient is started on a proton pump inhibitors stopped only when the patient dies. If for some reason it just continues and people forget to remove that from that. So be careful, stop PPIs unless absolutely necessary in patients with liver disease. They've got higher risk of infection too. Diagnosis, it's a clinical diagnosis. Patient has liver disease, no ammonia, no need of head imaging in there, okay? No need of special testing. So clinical diagnosis, patient has liver disease, looks confused, don't find any other cause, this is hepatic encephalopathy. No need to measure ammonia, usually causes more confusion in the mind of the physician than the patient, no need to check ammonia. Nutrition important. Don't restrict protein in these patients. Daily caloric intake, 35 to 40 daily protein. Vegetable protein is probably better, but generally don't restrict protein in these patients. Smaller meals work better for them. Try and give them a late night snack. You'll see the patient who has chronic encephalopathy has no muscle. If you have a little more muscle, less chronic encephalopathy. So give them some protein. Now lactulose, very sweet, traps ammonia, induces diarrhea. We use it for hepatic encephalopathy and constipation. What are the side effects? We went over bloating, they get cramps, they get hypernatremia and hypokalemia. So this is a study by Jaz Bajaj. You know Jaz Bajaj, incredibly smart person. I think he has done more in the management of hepatic encephalopathy nowadays than anyone I know. Very simple test. Everyone said you need 3 to 4 bowel movements per day for hepatic encephalopathy. So if you have 3 Bristol ones, that was considered enough. But this is a simple test. Look at Bristol. So quality more important than quantity. So generally, if you start off with 5, no need to add lactulose. On lactulose, if you have a Bristol 5, no need to increase. That's the take-home message. Rifaximin, oral, is a good drug used for traveler's diarrhea, small bowel bacterial overgrowth. Minimal side effects. Is it expensive here? More expensive than lactulose? Much more or a little? For us, it's much more. Much more. Okay, so then be careful. Then stick with lactulose, okay? Stick with lactulose. Don't use rifaximin very quickly in these patients. So here's how we're going to treat overt hepatic encephalopathy. First episode, grade 1. Start lactulose. Look for precipitating events. We went over the precipitating events before. Patient is better. Send patient home on lactulose. Patient is not better. Reevaluate. Make sure you've got a Bristol 5. You find reevaluation, my diagnosis is correct, stools are okay, no other precipitants, and this is grade 1 to 2, that's when you can add on rifaximin. If they resolve, continue lactulose and rifaximin. Worsening hepatic encephalopathy, let's go to the next algorithm, okay? So here is a patient with more advanced hepatic encephalopathy. Again, treat precipitating event, start lactulose. 3 and 4, you may need to put in a nasogastric tube or with an enema. Patient better, continue lactulose, but the difference here is once you've had your first episode of encephalopathy, then adding rifaximin helps. On the other hand, if you gave lactulose, no improvement, again reevaluate your diagnosis, make sure they've got enough stools. Diagnosis correct, stools okay, add rifaximin. Still not better. If the liver disease is not so bad, then they likely have a big shunt, which is bypassing the liver. Then you will get a CT scan, and if you have a shunt, then you will embolize. The problem is if you have no shunt at this stage, what you will do. We don't have Lola. Do you have Lola here? Yes. You find it good? Yes. No? I thought it won't be good. Some papers say good, but you don't think it's good. Yeah. Once we reach this stage, it's difficult. You know, it's basically a bad liver. No one finds it good? So what do you do at this stage? I want to know. We are limited in what we can do at this stage. What do you do here? You've tried everything, patient's not better. Not a transplant candidate. What's that? I mean, you could, you know, Mars has been used, but this is only very short term. I don't think we have good treatments once we reach that level. Okay? And once they've recovered, maintenance with lactulose and rifaximin. So that's your treatment. So, here are the answers. Do you remember these questions? Urine sodium was high, so discuss compliance with low salt diet. Anytime urine sodium is more than 90 and they're not losing weight, this is likely non-compliance. So, take home message, measure urine sodium if the ascites is difficult to control. Safety precautions, give albumin when you remove, give albumin 6 to 8 grams per liter when you remove acidic fluid. Typically give it within 6 hours of paracentesis because that's when the risk is. No worry about INR and platelets. Hepatorenal syndrome, most common is hypovolemia. Hepatorenal syndrome is only 25% of acute kidney injury. So replace volume in these patients. Currently is classified as HRS-AKI and HRS-NAKI. I won't go over that, no longer type 1 and 2. Urine sodium is not a criteria. Typically, it's renal vasoconstriction and extrarenal vasodilatation. And albumin and midodrine are not very effective drugs. Side effects of lactulose, hypokalemia, hyponatremia, abdominal bloating. Encephalopathy for type 1 stool, then you increase it. Otherwise, if encephalopathy is under control, or if you have Bristol 5, no need to increase. Varices, beta blockers, or ligation, both have side effects you must discuss before initiating. Once you bleed, use a combination. I've not gone over this, but tips when pharmacological and endoscopic therapy fails. Sites of action for ascites, diuretics, albumin, you have to remember all this, tips where it works, okay? Where vasoconstrictors work. So use diuretics judiciously. Renal dysfunction, watch. Side effects are a problem. You can carry out paracentesis safely. And encephalopathy take-home messages. It's a clinical diagnosis. Do not use ammonia for diagnosis of monitoring. Bristol 5 stools, rifaximin for lactulose failure, and thank you. SP, I'm on time.
Thank you, Patrick. I'm sure there must be questions from the audience. Any questions, comments, queries? You're most welcome. So everybody is so hungry now. Any question? Yeah, there's a question.
Weekly albumin in decompensated liver disease. Weekly albumin. Weekly albumin.
So the question is, what is the role of weekly albumin? So the Italian equivalent of INASL has recommended weekly albumin. No other society has recommended weekly albumin, and that's on weak data. So 2 studies, the Italian study said it helped, the Spanish study said it did not help. In hospital albumins associated with increased risk of pulmonary edema. Having said all that, there's probably a small group of patients who might benefit. Exactly which that group is, we don't know. So currently we do not recommend weekly albumin. It's also
Question, please.
expensive. Patient has to come into the hospital too.
Is there any role of statin in reducing portal pressure? Role of statin in reducing portal pressure.
No, there's more noise at the back.
Portal hypertension.
Statins in portal hypertension.
Statins.
It's already discussed about
Statins. I love statins. Me personal, why do I love statins? Decrease cardiovascular risk, probably decrease malignancy, delay Alzheimer's disease. I've been on statins for 30 years. Number of times I check my liver tests, 0. I love statins. Please use it. But in decompensated disease, we don't use statins.
Can we use tolvaptan if there is hyponatremia for short period?
Which one?
Tolvaptan.
Vaptans.
No, Vaptans for hyponatremia, very expensive, first of all, associated with renal injury, and was stopped as a recommendation. So no Vaptans.
Sir, recently Cook Medical has launched Hemospray in India. So do you have any experience of using Hemospray in variceal bleed, post-EVL
How can you
variceal
hear
bleed?
so well and I cannot hear?
Can come here and speak.
No.
No.
For variceal bleed. Roll of Hemospray for variceal.
Oh, Hemospray for variceal bleed. Oh, sorry. So question is role of Hemospray for variceal bleeding. There's probably a role. So the initial study that was done, those with Hemospray had less rebleeding. Okay, so you know the Hemospray. Do you have Hemospray here? Yes. So you know it comes in a complicated syringe that it has to meet at that point. So technically there have been difficulties in pushing it. But yes, there's probably a role there. Probably good for, I think the best indication is post-banding ulcer bleeding. You need something to spray there, it's good for that. So the question is aspirin in chronic liver disease. Remember, if chronic liver disease is related to mast cell, increased cardiovascular risk. So if you meet risk factors for cardiovascular risk, then you have to use aspirin. Remember, before it used to be anyone over the age of 40 consider aspirin, but now we know there's that bleeding risk. So you have to calculate the cardiovascular risk score. So it's called the ASCVD calculator. From that you know what their risk is. And if they're at an increased risk of cardiovascular risk, which means more than 4%, they should be on aspirin. I don't know about varices. There's a high risk of bleeding, correct. But remember, I always said, cardiac disease, you will die, bleed, we'll manage.
Thank you, Patrick, for a wonderful session, and thank you, audience. We close this session and invite Dr. S.P. Singh to propose a vote of thanks.